ITN distribution to optimize access. And I'm going to invite our moderator up. So that's Dr. Roch Akaikom, who's the Deputy Coordinator for NMCP Benin. So Dr. Roch, welcome up when you can introduce the first panel. So Dr. Roch, this is the Flickr. If people want, they have the Flickr when they have their slides. It's up to them. Okay. Or they can say next, and back there they'll advance them. Okay. Okay.
Alors, on peut démarrer. Bonjour, mesdames et messieurs. Good morning, ladies and gentlemen. And welcome to the day 2 of this meeting. We are going to start this session, which I'm pleased to moderate this morning. Without further ado, let's get started. This session is entitled Operationalizing ITN Distribution to Optimize Access. Based on the agenda, we have a total of 6 presentations this morning. Before we break for coffee, we will go through the first 3 presentations. And for that, I'd like to welcome on the stage our presenters. I mean, Katie. Is Katie around? Please, on the stage. Katie from AMP CDWG. And then Dr. Joe. Dr. Joe from Chai, who will borrow his voice for Wilson presentation. And the third presentation is for Gould Short. I think she will present online. So let's start by the first presenter, who is Katie. Katie will present about, assessing effectiveness and impact, ITN distribution channel selection and optimizing channel in use. Katie, over to you.
Good morning, everyone, and welcome to this session. So my name is Katie Sichalwe, and I'm from the National Malaria Elimination Program, coordinating the ITN program, and I'm also the co-chair for the MPCD working group. So I will be co-presenting with Mary. So we're both in black. Yes, so I will be co-presenting with Mary, and for this session, we'll take you through ITN distribution channel selection and optimizing channels in use. Okay.
Or you can see just a slide.
Just here.
Let's see slide in the mic. See slide.
Thank you very much. So from yesterday's discussions, we did notice that one key thing that kept coming out was we are working in resource-constrained times, especially with national malaria elimination programs. I think there's a lot of funding gaps in our ITN programming, and it is actually very critical for programs to adopt strategic and adaptable approaches to ITN programs. And as much as we have these funding gaps, it is very essential that effective ITNs continue to be selected according to the insecticide resistance profiles. And for this presentation, we're trying to encourage all national malaria elimination programs to work in line with the use of data for decision making, and also explore a channel of a mix and ensure sustained ITN access and use. And key to mention is that selection of both ITN type and optimal mix of ITN distribution is critical to maximizing impact. So the objective of this channel selection is to provide guidance to NMEPs in assessing existing distribution channel capacity, effectiveness, and efficiency in reaching and maintaining equitable access in targeted populations. And also we want to ensure that we understand strengths and limitations of each channel and distribution strategy, and determine the optimal ITN distribution channel and mix based on data and local context. So for this session, we'll be looking at number 2, but then we're encouraging people to join tomorrow's session in the afternoon, where we'll be looking at 1 and 2. So we also have a lot of work happening, going on under the AMP, and there is the link if you want more additional tools. So for today's discussion, optimizing channels that have been selected and that are in use. I'll start with mass campaigns, and then Mary will take us through the continuous distribution channels. We've been doing mass campaigns for over the years now, and we've been doing great. I think we can tap ourselves on the back for that. And just to, as we may all be aware, ITNs are rapidly, it's a channel that rapidly increases ITN access, and it's also used to achieve high and equitable access across the populations. But then, in this era where we found ourselves in, where funding is quite a challenge and the future is a bit uncertain, what type of considerations should programs put at play in trying to make sure that we do better for less, okay? So we've put up a few considerations that programs need to look at. However, we have a lot of technical experts in this room that can add to the list, but one of them is some operational considerations. We do understand that it's not a one-size-fits-all. So as we are doing our campaign, our ITN mass campaigns, it is recommended that we need to have it tailored to our local context. So I've given an example there. So where you find that a door-to-door approach in a hard-to-reach area may be more appropriate compared to a fixed point distribution that is done in a more accessible area. Additionally, we also need to look at entomological and epidemiological aspects. We need to tailor our interventions or our campaigns based on the malaria epidemiology. I'm sure most of the countries have stratified, we have epidemiological stratification in our countries, and it is very important to know where we're going to put which intervention. Is it ITNs, is it RIS? And we also need to understand our entomological data. Another thing at play is timing. So we do understand that we start planning for our campaigns a year or 2 years before, maybe 30 to 36 months prior. So because we want to ensure that we distribute our nets or deliver our nets at, which is very time sensitive, and that we operationally, we don't deliver the nets, and for instance, in the rainy season where you find that operationally it's very difficult to reach the intended beneficiaries. So then, what are some of the operational efficiencies that we think are critical within the current context? We've done a list, and we're trying to see how best we can learn from all the previous campaigns that we've done. We have a lot of experience. We've done campaigns over the years, and one of them is to try and learn from the previous campaigns, the lessons that we've learned. How best can we work with those lessons to improve to improve our operations with regards to campaigns in the coming years, and also to leverage on existing data. I think most of the programs in here have digitized their campaigns, and we've collected quite a lot of data with regards to campaigns, and we work with all these dashboards. What are we using that data for? Is it possible to go back to that data and see how best we can use it for the coming campaigns? So these are some of the efficiencies that we're trying to look at. And also the use of routine data. We're trying to collect data routinely through our DHIS2, HMIS, how are we using that data to inform our implementation of the campaigns? And is it possible to return or to consider returning to integrated or targeted campaigns? I think there's a lot of integration. There's the campaigns that are being included under the under 5 campaigns are being integrated with SMC. How is that working and how best can we integrate? And also probably changing the allocation. We are currently giving nets according to the number of people in the household, but is it possible to go back to capping? So I think as programs we need to start thinking and see how we can find efficiencies in how we are conducting our campaigns. And we're also thinking of combining microplanning and household registration. Is that possible? So these are some of the things, and the use of virtual tools and meetings to support health system actors. Each time we want to do an assessment, we want to hire a consultant, so we want to do an assessment, people have to go in the field, but that attracts a cost. But how best can we do that if we want to get data from the subnational levels? Is it possible to have virtual meetings? Is it possible to find adaptable tools that we can send to subnational levels so that we can get the data that we need to improve on our campaigns? At the end of the day, optimizing resources equals to saving lives. So with that, I'll end here and hand over to Mary to take us through the continuous distribution part. Thank you.
Down. Okay, great. Great, wonderful. Thank you, Ketty. Thank you, Dr. Rock. And hello, everyone. It's wonderful to be here. It's been a few years since I've been able to be here at the AMP meeting. So it's wonderful to see a lot of old friends and meet a lot of new people. My name is Mary Kante. I have a small consulting firm called Eau Claire Consulting, but for more than 20 years I was with the PSI team and got to work with a lot of you at Ministry of Health. So it's really wonderful to be here again. And as Ketty said, I'll say a few words about continuous distribution, and just want to thank Ketty for walking us through some of the existing resources that we have on the AMP website, the ITN distribution brief, which is there, which summarizes key recommendations from WHO and from AMP to date. As well as the last slide that Ketty was presenting includes information that will be in a forthcoming channel selection brief that will be coming out. So, I think it's really important work that AMP is doing to document all of the great work that you are doing so that we can share information across countries and across partners. So building on that information for how we can do more with less and respond to the unprecedented times that we're in now for campaigns, we want to take a look at available tools to assess and to optimize ITN continuous distribution channel, both the effectiveness as well as information to support channel selection. And I think what's important in this unprecedented time, and responding to Kate's call yesterday to be creative, to be innovative, to try new things, to do whatever we can to step outside the box, to improve and maximize access within whatever funding constraints that we have, that we do have a lot that we can look back on, both that's documented currently on the AMP site, as well as the great work that you all are doing. So one of the things that Ketty and I would like to come out of today is through the CD working group, the Continuous Distribution Working Group that Ketty leads with Prince Owusu, who couldn't be here today because of some of those funding constraints, is really a call to action and a call to gathering further information as well. So please do come and find us after, and we really do want to crowdsource as much information as we can moving forward. So That said, in terms of the continuous distribution channels, we'll start with looking at one of our most important channels, distribution through routine health services, often to pregnant women through ANC services and to young children through EPI services. And one tool that was developed a few years ago with Steve Poyer and myself and the PMI VectorLink team was a tool developed to assess routine distribution through a process assessment approach. And we were able to use this at the time with VectorLink staff in collaboration with Dr. Achu, who presented yesterday, and others, to take a look at to what extent is routine distribution, or this can also be applied to continuous distribution as well, to what extent is continuous distribution implemented according to existing guidelines, and from those observations, from the assessment, how can routine or continuous distribution efficiency be improved? And while we conducted this approach with dedicated PMI VectorLink staff at the time, and in collaboration with ministries of health, looking at how we could potentially leverage this and similar tools to do these kinds of assessments without having to bring in outside consultants, without having to even necessarily do all of the travel that we did. I mean, it was great. I was able to go, down to community level in 4 countries and be able to talk with community health workers, with heads of health facilities to get the information directly. But we do feel that this could be something that could be quite easily adapted through existing communication channels, existing meetings, that could be led by the Malaria Control Program in relationship with the Ministry of Health. We would need to drill down on that a little bit, but it's a fairly simple process assessment approach. And I will try to, how do I move to the next slide? Sorry? This one?
Yes, just say slide, then we'll change it for you.
Oh, okay. Next slide, please. Great. So this is just a quick snapshot. On the left-hand side is our simple analysis framework, and this essentially organizes the inputs by the key steps in really any usual program planning and implementation approach, and can be adapted to any specific programmatic approach, just going through each of the steps of the program planning cycle, from planning through implementation and monitoring and evaluation. And on the right-hand side of the table is just a snapshot of the teamwork approach that we had for the Cameroon assessment, and just showing sort of the different teams that were available in Cameroon. We did the assessment both in the north as well as in the far north, and as well as the interviews that we conducted at each of the levels. So it's a fairly simple and straightforward approach. Next slide, please. So we conducted these assessments in 4 countries, and as I said, we primarily focused at the time on routine distribution systems, and this could be applied to other continuous distribution channels as well. They were not widely implemented at the time in the 4 countries that we did the assessment, so we focused on routine distribution. So just a couple of the highlights from that, and I won't go too far into depth on any of these because there will be subsequent presentations today which will also present some more recent data on routine distribution. But these highlights I think are universal in terms of some of the challenges that were faced. So what we found in terms of planning was that for continuous distribution, for routine distribution, there are guidelines that can be found after many, many days of asking to find which laptop they are found on. So someone has them somewhere, but they're quite difficult to find, and they're not at the time, at least, were not readily available even to the malaria control program, and they certainly weren't available to the people who were implementing them. So this led to some of the other challenges that are listed here. So in terms of eligibility, in general, eligibility is quite well established. In some cases, it's clearly defined in the National Malaria Strategic Plan, which is more readily available. But it's not often disseminated and not often understood in the same way by everyone who's implementing from the regional, the district, health facility levels. So one example of a challenge that this created was in one country, as per standard, it was identified that pregnant women at their first ANC should receive an ITN, and we know why that's important. However, in one of the regions, they also had a performance-based financing project. And one of their indicators in order to achieve their outcomes for their performance-based financing was ANC4, also an important indicator. To achieve that indicator, they would only give the net to pregnant women at the fourth ANC, which, of course, was not as effective in protecting that pregnant woman during her pregnancy. So that government then subsequently worked on some national guidelines and worked to update that requirement. But as you can see, just the simple lack of availability of, a simple job aid that clarifies what the eligibility requirements are can reduce quite significantly pregnant women's access to ITNs through these longstanding routine systems. Supply chain, of course, there's always many challenges with supply chain. One of the significant ones, as you can imagine, is the last mile distribution. So we found that in most districts, there were ITNs available, sometimes so many that they were even a bit oversupplied in terms of the ITNs that were available for routine. However, the health facilities, even where the districts in some cases were oversupplied, many health facilities had stockouts recently, whereas other health facilities had too many. Because the nets often go through the free distribution channel, they're not necessarily in the national requisition system. At the time, there were not always clear pull requisition systems in place. It was much more of a, let's take a set number of nets out to the health facilities based on quite good information, and often it did work quite well for a fair number of the facilities, but others would be
Recording in progress.
oversupplied or undersupplied. Next slide, please. So other challenges were integrating training and information, so ensuring that this information could be getting out through other types of, this information could quite easily be incorporated in other health service delivery training for IPTP, case management, et cetera. In terms of communication, I did find it quite interesting that there was nothing. I didn't see a job aid. I went to 4 countries. I visited many, many health facilities, and I did not see any printed material. I did not see job aids. The posters that I saw were for the campaigns, often indicating the dates of the campaign, which might have been 1 or 2 years in the past. Even paintings, what you would normally expect. And I think what people told us is that the resources for communication materials were focused on campaigns, and once the campaign was done, there was not, the routine systems were a bit of an afterthought and sort of assumed that they would just function. So we may not still have funding for communication printed materials, but I think it is something to keep in mind. And then in terms of supervision and data management, there were many, many ways in which health workers were required to record the ITNs. So many ways that it was virtually impossible to really have a clear unified system to know how many nets were going into the health facility and how many were going to beneficiaries. There were, registers, and they were the information was reported generally through the monthly health system reports. However, there was also, there's a notebook, like the Cahier de Milda is also there, where people needed to record there. The registers, in many cases, did not have a pre-printed column to write the ITNs in, because they were registers for ANC and EPI. So health workers would write them in, but they're busy. They've got a million registers for a million different things and oversubscribed. So sometimes they would forget to write it in the register, but they would write it in the, in the notebook, the ITN notebook, et cetera. So some further support just to streamline things for the reporting, I think, would be very useful. So on this, I would just say again, we will be, Ketty, myself, with Marcy, Steve, and others, Prince, Robert, those of us who are in the Continuous Distribution Working Group. We're a really fun group. We would love to hear from you. We would love to hear, I'm sure there are many more experiences in the group of how people have resolved these. We want to pull together a toolkit to just have, some of these lessons learned and how people have overcome them. And I think we'll hear from Gulshad very soon. Great, next slide. Great. So we'll just briefly touch also then on school-based distribution and community-based distribution. So again, in order to look forward, we are going to look back a bit. PMI VectorWorks, which was the precursor to VectorLink, has a tool available, which is a question table to guide some of these choices. So these are just some of the questions that are available there. And in our session tomorrow, plug for that, please come tomorrow afternoon and we will do some deep diving, and we'll have some links and printouts to this to go further into depth. But it's a tool that's available that can walk through essentially some of the key questions and then provide some guidance for next steps. And for example, some of the questions: would it be practical for health facilities to conduct ITN distribution as outreach? Is primary school attendance fair to good in some areas of the country? Do you have any serious concerns about the feasibility or cost of ensuring a supply chain through any of the channels? And then other key considerations around storage, understanding access to and quality of community health worker networks if you're considering community-based distribution. And exploring the combination, for example, of ICCM and ITN distribution, which I believe our wonderful team from CAR is exploring. So we'll hope to hear more from them also tomorrow in our afternoon session. Great, next slide, please. So in terms of these channels of school-based distribution and community-based distribution, we'll also hear tomorrow from Tanzania, CAR, and Zimbabwe on their great experiences. We've been working to pull together all of the information that we have, and very soon we will have a new toolkit available on the AMP site. This is the mock-up that we have, so we have this draft toolkit walking through 9 key areas: 3 upstream, coordination, channel selection, quantification, waste management, and then 6 operational areas that you see here for planning, logistics, training, SBC, distribution, M&E. So we've pulled together key information as well as key examples and tools. Next slide, please. Great, and alongside the main information that we have regarding school-based distribution, we've also done quite a lot of work to develop a set of adaptable tools through the CD working group. And one includes a plan of action template, which provides a very simple framework and guidance on key information that you would need to develop a plan of action specific to school-based distribution for each of the steps that we just mentioned. Also, a risk assessment and mitigation plan, Excel template, terms of reference, samples, and budget and planning checklist to walk through some of the planning details, as well as an adaptable timeline. And with that, I will pass back to Ketty to wrap up and talk about some of the other types of channels and next steps. Thanks.
Thank you very much, Mary. So we've already been given a reminder on time. Next slide, please. So this is just to recognize some of the community, some of the countries that have done community distribution. We know we've done community in Burundi, Madagascar, Zanzibar, and also Zimbabwe. And just like Mary mentioned, we will deep dive into all these tomorrow. Next slide. And maybe some of the considerations that countries need to look at is also to promote the net culture. Are people willing to even go and get a net on their own without, if that or they don't receive a free net? So these are some of the considerations and questions that we have on that. And also trying to promote social marketing, but at a very low cost. That is also non-standardized sales. Next slide, please. So the question is, what are some of the future perspectives towards channel selection and looking at all these channels that we are using to deliver the nets to the different beneficiaries? So one key thing to mention is the context will still continue to evolve, and we need country-led expertise and experience to lead the process, because we are the technocrats. We do understand what our challenges are, and we do understand what our cost drivers are. So it's very important that we lead the process and really coordinate and be more creative as we pick which approaches we're going to select to maximize on our channels and impact. Next slide. So before we get questions from you, we have a set of questions that we have, and we don't expect, these are just to push people to start thinking. What are your impressions and thoughts of optimizing channels selected in use and presented? And also, what are some of the proposed items that may work better? I had already mentioned that it's not a one-size-fits-all, so looking at your country context, what do you think would work better for you? And also some of the considerations or questions that you would add to the list that we had shared. And would also like to hear from you which other ideas and innovations will be more for operational efficiencies are you considering or would propose to consider as we plan for our IT and distribution channels. Thank you very much. We'll end here.
Thank you, Katie and Mary, for this nice presentation. Now I'd like to invite Dr. Joe from CHAI for the second presentation, which is entitled Assessment and the Selection of Channels for IT and Distribution in Zimbabwe. Dr. Joe, over.
Good morning, everyone. Bonjour. Bon dia. Yeah, as Dr. Rock indicated, my name is Joseph Shoushoma from Clinton Health. I'll be presenting on behalf of Mr. Wilson Chauke, who's the Vector Control Lead for National Malaria Control Program in Zimbabwe. He couldn't be here in person, as well as attending online due to other pressing commitments. However, there is a caveat to my presentation. I'll collect all the questions that will come from the floor, as well as online, and give it over to him to answer later on. So I won't be able to respond to your questions. Yeah, so I'll just give you a snapshot of how Zimbabwe is in terms of EPI and how that influences the choice of deployment of interventions. So as you can see from the map, the malaria in Zimbabwe is mainly concentrated around the border. To the east, we have Mozambique, and then going up to the north, we have Zambia. This is mainly, how the malaria is structured in Zimbabwe, the transmission. So Zimbabwe uses an IVM approach to intervention, with the core being IRS and ITNs. which have specific criteria for deployment as indicated in the slides. As I've indicated, vector control measures, IRS and LINs, which are the core, and then larval source management and house screening. When it comes to parasite targeting, diagnosis and treatment, IPTP and MDA, and this is all anchored on the strong surveillance, program management, and SBCC. So Zimbabwe employs the channel, as I indicated, for ITNs, and this covers approximately 48% of the population. Mass campaigns are targeted after every other 3 years, and they do what they call rolling campaigns, where they happen at different times, but after every other 3 years, depending on when the district was moved from IRS to ITNs, as per the API criteria I indicated. So this is one of the channel mass campaigns. So the other 3 key channels used are routine, ANC and AP, and also community. I think as you can see from the pictures here, we have community-based distribution through village health workers. Also to note that approximately 50% of the cases in Zimbabwe are reported by village health workers. So they have a very strong village health workforce system that is in place to quickly pick up cases. The next is around at AP and ANC facilities, and then on the mass campaign side. So how did it start, and at what point did the NMCP say we need to utilize this channel? The NMCP has always been acknowledging tropical health. I think they were part of the team that helped do the study and supported them. So around 2015 to mid-2017, a number of channels were reviewed, and this included 4 specific channels, school-based, NCAP, and community. As you can see, there were some key issues why and rationale why specific channels were used for. For example, for the school channel, mainly it was around the vulnerability of the kids, and for NCAP, our biologically weakened population groups, which are the under 5s and pregnant women. And then for the community channel, it was also to replenish and ensure that there is continued coverage after mass campaigns. So this pilot study took around 36 months, and it came to the conclusion that we needed to prioritize and focus on X channels after having considered some indicators that were measured. I won't go through each line by line so that Doc doesn't pull me back here. So there was a decision that was made at that point whether to go with the community channel or the school channel. But at the close of the study, with the analysis that was done, the conclusion was that the community channel was the most effective and probably more suitable for Zimbabwe, as well as NCAP. So as I indicated earlier, so currently the country utilizes routine channels, that's your ANC and AP, as well as the community channel. And the community channel uses a coupon system. I think Mr. Chauke will be able to talk more through this tomorrow so that there is more understanding of how they're doing, best practice, and also cross-learnings from other countries. As I indicated, Zimbabwe conducts community distribution in years between mass campaigns. This is mainly there to ensure that there is continued replenishment of the nets due to the losses. As you can see, the assumptions that are done in terms of the loss rates from year 1 up to year 3, then the continuous distribution through community ensures that there is continued saturation of the nets before the next mass campaign starts. This is just to show guidance that is there across on quantification and guidance. I will not go through this, and also this is specific to the quantification assumptions used by the country around growth rates and what population quantifiers can be used to calculate ITNs for continuous distribution. I'll skip this. This is under the current grant, the GC7, how they intend to, deploy continuous distribution until 2026. Yeah. So from the assessment, and I think I would want to focus a bit on this slide. Mainly, it's around each channel, what was observed, and recommendations and what can be done. So the community channel is really a key channel. As I indicated, community health workers or village health workers in Zimbabwe are a key cornerstone of the public health work or malaria prevention that happens in Zimbabwe. And the strength of this channel has been mainly around, reporting, good reporting, use of a good coupon system, so that, no one is missed and there is continued replenishment. However, they've indicated that there is need for improvement, especially around storage of these nets, coupon eligibility, sometimes probably not checked when they're being issued, and then also the need to improve on records management as indicated here, and the country is working very hard to ensure that these recommendations are tracked and are timed so that there's continuous strengthening of this community channel. Yeah, hopefully Mr. Chauke will also be able to deep dive into this on tomorrow's presentation. This is just to show the documentation that's involved to ensure that there's accountability and good practice when it comes to community distribution. Yeah, so just to add in Zimbabwe, community channel approximately is probably twice as much compared to ANC and AP. As I indicated, Zimbabwe is close to 20,000 community health workers, each community health worker, covering about 100 households. So there's a deep-rooted network of community health workers who can support and ensure that nets are distributed to the community. So this channel is more active compared to the ANC and AP channels. So what has been the lessons learned here? Community channel is very key. I think after deliberations and how the public health space is structured in Zimbabwe, the school distribution was dropped, and there is continuous strengthening and continuous demand creation within the community members for nets, with a strong, robust coupon system to ensure that there is accountability in all the issuance. And there is strong collaboration between the National Malaria Control Program with other Ministry of Health arms when it comes to NC and EPI to ensure that there is minimal stockouts, the channel is effectively used, and protect our vulnerable populations who are the under 5s and pregnant women. So in conclusion, the adoption of the community-based system has managed to ensure that demand is driven within the communities instead of just pushing nets down, so that utilization is per need. This reduces wastage and pilferage. As I've indicated, I think the community-based distribution system has fully utilized the coupon system. As you might know, some health facilities may be hard to reach and may be far off, but utilizing health workers who are within the communities has managed to increase access and ensure that distance is not a barrier to access for ITNs. There's continuous improvement when it comes to quantification and targeting, also aligned to population growth and changes. However, the country envisions to continue increasing this as they accelerate towards getting to below 5 cases per 1,000 population. This is the end of Mr. Chauke's presentation. So hopefully we can learn more from him tomorrow if he manages to join and explore and get into detail when it comes to community distribution. Thank you, Tim.
Okay, thank you, Joe, for your presentation. We have 2 nice presentations related to continue ITN distribution channels assessment. We will take some questions about these 2 presentations. I don't know, Giovanni, if you have any question on the chat. Okay, perfect. So let's take a series of 2 questions due to the constraints we have in our agenda. Okay, mic for the audience, please. Okay, we have 2 hands, yes.
Hi there. I was curious for thoughts on how the costs compare across different continuous distribution channels, across each other and also in comparison to mass campaigns, and how much the thinking is either that it's can generate demand or more successfully target under 5s, and so higher costs are fine, or if there's cases where you found actually lower costs from continuous distribution channels. Thanks.
Okay, thank you. Okay, let's go, please.
Hi, my question is about relative shares across the channels. So what proportion of total nets are currently going through the continuous distribution channels in your country? And even with expansion, what share do you anticipate it going up to? So if it was at 5% of all nets now, even with massive success, what do you see it getting up to? What share of nets going through that channel? Thank you.
Okay, thank you. Okay, Giovanni, let's go, please.
Thank you, the presenters. I was wondering, there is one channel they are mentioning, but I think we need to be bold about now, especially in the current context. I mean the private sector channel, you know. If you want to sustain access and coverage, I think we need to be more bold about engaging this channel beyond these traditional mass campaigns and routine distributions. I think this is something we need to think more about now. Thank you.
Okay, let's give the floor to the presenters. Okay, we will see, with the hope we can continue discussion during the break, the coffee break, I mean. Thank you. Okay, Katie, Mary, floor.
Yeah, great. Thanks everyone for the good questions and some tough questions as well. I'll start with the private sector question, going back to my roots at PSI. I think, I think it's something that it merits some deeper conversations. Sorry. I think it's a very important question in terms of within the current funding context, as well as difficult decisions on prioritization to ensure that we can have conversations with all of the net manufacturers as well as governments in terms of perhaps moving away from old school sort of social marketing, which is not free or cheap necessarily to do social marketing from experience. However, there is a lot of learning in the market facilitation space and working with the many manufacturers. It's a very different context than what we had in 2000, and I think working with the net manufacturers in terms of finding ways in which we can more creatively leverage the private sector is key. So would love to talk with folks, and I know folks at IVCC and elsewhere are also quite interested in that topic. I'll touch on the question of the cost comparison. I think it's a very good question. There was a paper that I believe was done by Vector Link, but I need to put my fingers on it, that does compare costs. I mean, we know that routine channels are the most cost effective, and also just to say that in terms of channel selection, if nothing else, we have to start with and continue routine distribution. It should not be a channel that's X'd out in doing your channel selection. So we know that it's very cost effective, and I believe, others in the room may know this better than I, but that there are it's relatively similar costs for school-based distribution and campaigns. I think there's some papers by UKIC and others that we can find that have more specifics on that. Over.
Okay, Katie, do you want to add something?
Thank you very much, Mary. So just to add on what Mary said, if we compare the cost between continuous distribution channels and mass campaigns, you find that continuous distribution costs are much lower. So when you look at the mass campaigns, we'll find different unit costs, operational costs per country, but then it's for us to procure and deliver the nets to the households, we're looking at probably $4, $5 per net. But then when you compare it to continuous distribution channels, you're looking at $3 per net. So there's some assessment that has been done on costs, I'm sure, like Mary mentioned, by PMI Vector Link from different countries. We can, if you check on the website, there should be some paper on that. And just to add on Giovanni's question, or maybe let me just say addition, it's really very good to bring the private sector on board, looking at the current context that our programs are currently working in. And it would really be helpful if we can allow the communities out there to also have the zeal to go out there and buy a net, even at a subsidized price. So I think that is one of the considerations that as programs we need to start looking at. Thank you.
Yeah,
Okay.
I think there was a straightforward question around what percentage is going through the channels, if I got that question right. So per the presentation I did, specifically for the community channel, it's fixed at 5%, and then AP and ANC, that's 3% each. So in total, 11% of the nets are going through the continuous distribution channel, yeah. Yeah, likely to rise as we go into this difficult funding space. We are likely to see probably across many countries, focus being more on the continuous distribution as a channel that can probably supplement the mass campaign channel. So likely to go up into the future, yeah.
Okay, thank you. We can take 2 more questions, if any. Yes.
Thank you so much. My question goes straight to the community distribution. I see the good delivery mechanism of ITN. However, I was trying to think about the coupons provided by the SHWs. And this also happened in Zanzibar, a nearby country. There were kind of an inequity in terms of distributing of that coupon to the really need. For example, maybe due to political issue in different party, other cynics and other. How do you manage to tackle in Zimbabwe so that you can have an equitable? Because in a conclusion, we've cited that we actually facilitated the equitable distribution of the net among community compared to the SMP or SCBD. So how do you manage that up to the community level? Thank you.
I think Mr. Chauke will tackle more on that tomorrow as well, but how the community health system is structured in Zimbabwe, they usually pick the respectable elders in the community to do that, and they are more prone to respect and less manipulation. Though that has really helped, as I indicated in the slides, more equitable and fair and more accountability when it comes to that coupon system. So they usually pick the elders and more respected in the community to be the community health workers. Yeah. So it reduces that risk of manipulation and unfair distribution or treatment. Yeah, because no one can come ahead and influence them most times.
Yeah, thanks for that, Dr. Joseph. And I think just adding on that as well, I think the Madagascar team is here, and they also had quite a long history of doing community-directed distribution that was part of their national strategic plan. I think that has evolved, but I think also probably some good lessons learned also from Madagascar in terms of working with a very strong community health system structure that I would imagine also had some of those similar issues. And I would imagine that by having more than one health worker per community also could perhaps mitigate that if there are 2 or 3 health workers who could be in the community. Over.
Okay, thank you. Thank you very much. I'd like to ensure that Gold Shot is online. Giovanni.
Yes, he's online.
Okay, okay. She's going to do the 3rd presentation, which is about factors influencing routine distribution and the lesson learned. So I'd like to invite Gulcho for the presentation. Over to you, please.
Hi, good morning to all, and good afternoon to all the participants in Asia. Can you hear me well?
Yes, we can hear you.
Wonderful. I would love to be there with you in person, but unfortunately I couldn't come. So I would like to thank the Alliance for Malaria Prevention for this opportunity to present today the factors influencing routine ITN distribution and our lessons learned. But maybe firstly, a little bit about myself. My name is Gulshat Alibirgenova, and I'm the monitoring and evaluation team leader in the UNDP Global Fund Partnership Team. And our team provides technical and advisory support to UNDP program management units managing Global Fund grants. Next, please. Yeah. So after a short background, we will first look at the programmatic performance of ITN distribution in the past 3 years in the Global Fund grants managed by UNDP. Then I shall focus on the factors negatively influencing continuous distribution and specific remedial actions. And then we shall talk about the factors positively influencing continuous distribution, and we'll conclude with the summary of the lessons learned. Next. UNDP manages a large portfolio of the Global Fund grants, and among these grants, 9 of them are implementing malaria interventions in the current funding cycle called GC7. Routine distribution or continuous distribution, I use the terms interchangeably. It has been a focus area of our team since the last funding cycle. Firstly, I mean, in the previous session, the importance and the growing importance of continuous distribution has been well emphasized. Yeah, so we're aware of this, and there have been a lot of challenges. This has been one of the areas of poor performance in the previous funding cycle. So we focused on it, working with our program management units, trying to understand what is going on, why, what can be done, what is being done. Yeah, and we actually conducted a knowledge webinar. Exchange webinar. In fact, it was in 24, but we used 2023 programmatic results. Yeah, next. So before we talk about the continuous distribution, I just would like to give a quick overview of the ITN distribution through campaigns. So these are the results for 2023. For all the grants that implemented mass campaigns during that year. And what we can see here, almost all grants, with one exception, that was Haiti, achieved very good results, meeting or nearly meeting the distribution targets, and there were even a couple of cases that were overachieving. Just to be more accurate, I'd like to say that nearly 95% of distribution was attributable to distribution in 3 countries with large-scale campaigns: Chad, Angola, and Guinea-Bissau. Yeah? So what we are seeing also in 2024, based on the analysis of the recent results, 2 countries that implemented mass campaigns, they also have strong results. So this is a fairly area of consistent good performance. Yeah, next. Now, the picture is somewhat different for continuous ITN distribution, and among the targeted groups here, like we have such targeted groups as pregnant women, in some cases children under 1, in some cases children under 5, school children. I mean, only one of the grants had school children, and there are other vulnerable population groups, for example, internally displaced people, or like returnees after a specific crisis. So what we are seeing here, particularly in 22 and 23, performance of this indicator, in other words, like meeting targets, has not been that great. Yeah, we only had 1 country in the portfolio in the previous funding cycle, GC6, that actually met and overachieved the targets. That was Afghanistan. All other countries couldn't meet the target, and in some cases it was sort of moderate performance, but we had nearly half of the portfolio implementing malaria grants that had poor performance. Yeah, and we are going to talk about the reasons for this. But before we do that, I also would like to now zoom on the 2024 performance. And this is based on the recently reported data. So what we are seeing in 2024, in the first semester, the performance was still fairly weak. I would say mixed to weak, yeah? Then in the second semester of 2024, it has picked up quite considerably. There are some countries sort of grant specific. For example, two of the grants, like Angola and Chad, in the first semester of 24, they were completing the last implementation period under the previous funding cycle. So they had still targets that were previous funding cycle targets, yeah? And then during GC7 negotiations, the targets have been renegotiated based on the lessons learned from implementation during the previous funding cycle, yeah? Then we have some other cases. For example, in Haiti, they couldn't get the nets procured on time, and that's why the first semester distribution was very weak. They were essentially distributing what was left over from the previous cycle, yeah? And it started picking up in the second semester. And for cases like Venezuela, you may say, wow, how did they manage to go from like 26% to over 120%? It's actually interesting. In the first implementation period of the new funding cycle, what happened is providers were distributing nets both to pregnant women and to children under 5. However, in the design of the grant, they were meant to target only pregnant women. You know, so in a way, the distribution got sort of expanded. This was caught, of course, during the reporting, and then corrective actions were taken. Specific guidance was provided, but whatever was distributed to under 5s wasn't reported because couldn't be reported because it wasn't aligned with the definition of the indicator. So you can see the reasons here vary, but I'd like actually to take a deeper dive, into the factors influencing performance. Next slide, please. Yeah. So this just gives you an overview of the average performance across the portfolio for continuous distribution. And as we looked at the previous slide, as we could see on the previous slide, the last semester of 24 shows really much stronger performance. Yeah, next. Okay, here we have listed different factors that have negatively influenced continuous distribution. In other words, these are the different challenges that we've seen in grants. Typically, most grants had more than one challenge, and some of them were very common. For example, the first two, low coverage of antenatal care and immunization services, and gaps in data collection tools and data entry deficiencies. This was the case at least in half of the portfolio implementing malaria grants. Yeah, some grants had challenges and suboptimal coordination of different stakeholders, and also not very clear guidance to providers of services. We had some cases of shortages and stockouts of ITNs, and particularly, in cases where this happened, this was typically due to supply chain challenges and basically timely supply of ITNs from the district level to the health facility level, In most cases, those ITNs, they were in stock at the central level, yeah? Then we we had, particularly in 22 and early 23, some grants reported that fuel shortages have really impacted distribution and monitoring and supervision activities. This was at the time when the oil price went up, and you know, like there were issues basically in scraping up the funds for fuel. And then among the last but not the least, there are two other reasons. We have noticed that in the previous funding cycle, there were a few cases of fairly ambitious target setting that was based on the assumption of sort of percentage of antenatal care attendance, for example, based on the national plan. So it wasn't really based on the actual attendance, but rather the aspiration, the targeted attendance, which in many countries didn't really materialize. So we had cases where ITNs were purchased in stock, but because of the ambitious target setting, really like the real achievement was much, much lower. And then we have also seen some cases where there were differences in beneficiaries between the program design and actual implementation. I already mentioned one case, like in Venezuela, how they were erroneously targeting under fives during the first cycle of implementation, and then this was corrected. But we also had at least two other similar examples. Yeah. So, for example, they were meant to target only under ones, but they expanded to under fives, or it was the contrary. Yeah. So these are essentially the factors that have negatively impacted distribution. Yeah. And now we are going to look at examples of remedial actions. And clearly, I mean, all of this is taken from the reports and our follow-up meetings with the program management units, yeah? So this is not fully this is not an exhaustive list, but some of the examples. So to address low coverage of antenatal and immunization services, the most common actions included like community mobilization, and also campaigns at the health facility level, as well as, ideas to engage more traditional healers who have trust of the communities they serve, who are close enough to them to encourage attendance of these services. Of course, what cannot be influenced is such factors as the distance to facilities or availability of health workers in facilities to provide services. Yeah. To address ambitious target setting, I mean, we have been encouraging program management units to work closely with the national stakeholders and to really do good analysis of previous cycles' performance and look at target setting assumptions for the new cycle. Yeah, and then like in grant negotiation meetings, there were extensive discussions with the Global Fund colleagues about target setting for the new cycle. Yeah, and then like ensuring alignment between target beneficiaries and actual beneficiaries. Yes, I mean, we see two examples like from that started recently, GC7 implementation, where after the first period of implementation or towards the end of it, they identified that, okay, we are not entirely targeting the correct people. So, and corrective actions were taken basically, yeah? So, next please. Yeah, as I mentioned, one of the common issues was also gaps in data collection tools, and this is truly common, like the cases of antenatal care registers not having a specific field to track distribution. This or EPI registers having a similar problem, not enough coordination with maternal child health program, for example. These are fairly common reasons, and then of course data completeness in the systems. Yeah, so in terms of remedial actions, again, like one needs to focus more on data analysis and focus on quality of implementation through monitoring missions, as well as invest in formative supervision. I understand this is going to be increasingly challenging to ensure frequent supervisions, yeah. However, once supervisions are done, focusing both on data quality and on the quality of services, common observations need to be followed up. Yeah, and of course working on the forms, like adjusting the forms in collaboration with the relevant partners, printing, disseminating, training people, that is crucial. There is one nice example from Guinea-Bissau, a very recent example actually. As the team in Guinea-Bissau was analyzing performance, which was historically low for this indicator, they found some data gaps in DHIS2 in collaboration with PNLP, with the National Malaria Control Program. And so they compared, they found data gaps, and they pretty much agreed and started implementing the solution, i.e. data catch-up, to make sure that the data reflected in the reports was completely entered into DHIS2. And it was really, really a considerable improvement of the result compared to the previous semester, yeah? The result in Guinea-Bissau went up from 46% in the first semester to 75%. Of course, it is important to say it wasn't just this measure, yeah? There were a number of measures implemented, but this was one of the important ones, yeah? Next, please. And these are other measures, like enforcing supervision visits, making sure like there are mechanisms to enhance the supply chain, and also where needed, look for funds reallocation, if there are specific savings, and then put the money where it really could help enhancing the distribution, yeah? Okay, thank you. And here we have a summary of factors positively influencing. It's a mix of factors and some success stories as well from the country level, yeah? So it's good coordination between different stakeholders plays a huge role. Yeah, like I mentioned earlier how Afghanistan succeeded. It was the only country that succeeded in terms of meeting and overachieving their targets in GC6. So they used the one-team approach where they would regularly have coordination meetings, data review meetings, and also as part of the implementation arrangement, they engaged a primary healthcare provider as an implementer, and ITN distribution was done through midwives and regularly monitored, yeah? Another example is also actually from Guinea-Bissau. The Global Fund grant is supporting a stronger collaboration between the National Malaria Control Program and both immunization and maternal and child health programs, yeah? The third example actually is from Chad, and that is using modern technologies and new common ways of communication to have prompt follow-ups and communication. So they've been setting up WhatsApp groups at different level, and like connecting central with provincial levels, district level working groups, specifically focusing on health facility managers. So this has been of great help as well. I mean, Chad had a pretty considerable performance improvement after implementing this, among other measures. And then timely reporting. I mean, reporting is reporting, you know. Unfortunately, it's often perceived as the end game, but in reality, reporting is not very useful if there is no regular analysis and follow-up. And that has been fairly key. Like in this case, I quote example from Afghanistan, but this would apply to any other country. Yeah, and then, of course, having clear guidelines on the target groups and specific instructions, and very importantly, forms to capture distribution. Otherwise, we will be always underreporting the actual state of distribution. Yeah, okay. Next, please. Yes, and this is actually, I'd like to give an example from Chad. Which also Chad had continuous, sort of moderate, weak performance. And one of the causes actually of this that was found during monitoring visits by the colleagues and national program was that ITN distribution actually wasn't done during the first contact with pregnant women and with children, yeah? So once this issue was observed in a number of facilities, then there was quite a bit of work done, and a special circular was prepared and issued by the Secretary General of the Ministry of Health, which is very, very good. I included the example here because once you have the material, you can zoom in, you can see. It's not just sort of stating the theory of distribution or why it's there. It's giving numbers and it emphasizes why it is important to give nets at the first contact. So again, the performance of this indicator went up quite considerably. This was one of the measures taken along with the other measures. Next, please. So just to summarize now, the lessons learned that were observed in different contexts. Involving key actors is very important, and not just during the programming, but throughout implementation. Number two, it definitely pays off investing in developing and improving data collection and reporting forms. Yeah. Number three, regular data analysis, and not only analyzing, but taking follow-up actions, being clear on who is going to do what about the problems that were found. Yeah. And then monitoring availability, yeah, and distribution practices. Continuous monitoring and noting down issues, it can really help to improve implementation. And you've seen some examples where it improved really over a few months, yeah? And this can be also a great input to shape the future programming, yeah? And of course, one needs to be seeing in the context of limited resources, this will become even more pertinent, looking at the longer term trends and then prioritizing the target groups, target geographies, yeah. And also, we shouldn't be shy to highlight instances where targets may have been set over optimistically, yeah. From experience, I know that Global Fund colleagues are actually open to such discussions, but they do need to be evidence-based. We couldn't just say, oh, performance wasn't good, so we want to change the target. Yeah, there needs to be concrete evidence, and then this can help in setting a more realistic target and freeing up resources for where they are needed. Yeah. Next, please. And here I would like to thank our colleagues in the program management units in Afghanistan, Dr. Ahmad Walid and Dr. Saeed Aoud Mahmoudi, colleagues in Chad, Aisha Muhammad Ali, who is now in Burundi actually, and Mr. Ole Bahamla, and our colleague in Guinea-Bissau, Ms. Ghislaine Grasser. Yeah, they've given great contributions and you know, of real experiences from country level. And of course, huge thanks goes to all the implementers, with national malaria control programs in the lead. Thank you. And I look forward to your questions and feedback.
The factors influencing routine distribution. We have time for about 2 questions. Mic for audience, please. Yes.
Okay, thank you for the presentation. My name is Geronimo Zanamela, and I work for AMP. So I heard you saying in one of the slides that negative factors that are impacting the continuous distribution. So one of them under these ones is ambitious target setting, and in brackets you see you have like impact of mass distribution of ITNs. So I would like to maybe to hear from you elaboration a bit more in terms of what is this. Maybe that will support stronger recommendations to this point. Over. Thank you.
Thank you very much, Dr. Geronimo, because this is something that I failed to mention about the impact of mass distribution. Yeah, ambitious target setting, it can be purely for this indicator because of the, let's say, specific assumptions on who are our target beneficiaries, what is the percentage of those, for example, attending antenatal care services. You know, it can be ambitious target setting purely for this indicator, but it can also be ambitious target setting in connection with mass distribution activities. You know, and this actually we saw in the previous funding cycle towards the end of it. As one of the explanation in a couple of grants, it was like, because of the mass campaign activities, basically the demand for receiving nets during routine services, it reduced, yeah? So I think here it's like, perhaps in the context of resources becoming more and more limited, we need to see if mass campaign is still playing a big role and covering most population groups, then we maybe need to see how the target should be set during that specific year for routine services. Yeah, so that is what this is about. But I'm certainly interested to hear views of different participants here. You might disagree, but yeah, I hope this clarifies.
Okay, thank you. One question else, yeah.
Thank for to the presenter. Just a few questions from her experience. I see that performance is usually very high, you know, after the campaign distribution. But in terms of coverage, we find out that it's usually very low. I mean, low in general. What is your experience?
Maybe you could clarify, are you referring to the mass campaign, to the slide I presented earlier on the mass campaign? Okay. Well, I think talking of the coverage, we would need to be very sort of country specific. Yeah, it's, we need to see, I mean, I think it would be difficult to do at the level of the portfolio. You know, we would need to see country by country. And if there is a particular country of interest for you, I'll definitely can look up and get back to you. Yeah, but coverage is something we can typically see from the surveys. And yesterday, I actually particularly appreciated a point made by Molly Robertson in her presentation about looking at the use to access ratio. Yeah, I think when we do that, it's really, if we look in a disconnected way at those who have nets and those who use them, we don't get that good quality data. You know, I mean, we don't get, it's hard to interpret it. But if we link up use to access, then it's a totally different picture. And then if we see that the percentages are low, then we definitely have to understand why. Is it because of the user preferences of specific nets? Is it because of other reasons, you know? But I know I'm not really answering your question, but I would appreciate maybe if you are interested in any particular country, I can get back to you.
Okay, thank you. Time is over. Ladies and gentlemen, please a round of applause for our presenters.
Thank you very much.
Before we break for coffee, I'd like to invite Robert to briefly share some key information about tomorrow's session. Yes, please.
Can I have the QR code? So for tomorrow's technical working session, we have 4 main sessions. We would like you to please select your session to help us to identify the rooms. So by the time we leave here, we will show you the rooms you go tomorrow. But there are 4 sessions. The first one is on the GIS training. On the GIS training, we have Francophone and Anglophone. Please, for all the French-speaking people, kindly select French, and for English, you select the English, because we are not going to have interpretation. On the others, there will be interpretation for them. So the other one is the waste management, repurposing, and end of life. And then in the afternoon, we have 2 sessions, which is on implementation of the GIS1 or standard ITN labeling, and the other one is on continual distribution. So please kindly select this one so that we are able to identify the rooms and where each participant will be. We have the QR code on the screen. There are also a sheet of paper on the tables. You find it there. Yes, sheet of paper. If you haven't seen it, please, it's on the screen. Kindly do it before you go for the break so we know how many people are going to each of the rooms. Thank you.
Thank you, Robert. Time is for coffee. Let's come back here at 11 sharp. Thank you. Okay, welcome back. We will continue our session with a series of 3 other presentations. And for that, I'd like to welcome the presenters. I mean, Peter Gitenya from NMCP Tanzania. Is Peter around? Ah, it's you. Marcel from SLP. Marcel. Matthew from World Vision, and Madi from NMCP Mali. Please come on the stage. Madi from NMCP Mali. Ah, it's you. Okay. Okay, thank you. Welcome once again. Peter is going to present findings from ANC and EPI ITN distribution performance in mainland Tanzania over 5 years. I'd like to invite Peter, okay, on the stage. Over to you, Peter.
Thank you, Chairman.
You know how to use this one?
No.
What you can just ask.
What is the next? Finishing the next? Yeah. Good afternoon, everybody. I'm Peter from mainland Tanzania. I'll be taking you through the assessment of the performance of ITN distribution via health facility to the target group ANC and the EPI. This experience over 5 years, from 2018 to 2022. I don't know the next page. Next slide. So, starting with the introductions. It's not responding. Maybe it is. Next slide. Okay. Yeah, this is my presentation outline. By starting with the national ITN strategy in Tanzania mainland, our strategy, we aim to deploy ITN as one of the key vector control interventions, has been used to in contribution toward the reduction of malaria in the country. This is according to our national strategic plan 2021-2025. But our strategy, one of them is to distribute ITNs to the health facility, which I'm going to talk about today. But also we do via mass campaign, but also we do via school net programs. But the aim is just to reduce the malaria prevalence in the country, which currently is 8.1 to at least less than 3.5 by this year when we do our programmatic review. Just a background, we know ITNs contribute a lot toward malaria burden reduction worldwide, and we know routine health facility is also one of the delivery mechanisms, and also help to maintain ITN access at least to optimal level for our country, let's say 80%. But also ANC, for in Tanzania, we give to the first attendees of first ANC pregnant women, but also for infants, we issue a free net for the children when they come for first measles rubella. So we have a really clear cut of the whom we do issue the ITNs. And this program was being reintroduced in year 2016, and currently is operating 100% in all 26 regions and in all health facility. So this is a map of Tanzania mainland showing a stratification, a malaria burden of the country. The red color indicates high malaria burden, and yellow represents moderated malaria transmission, while the pale green, I think it's a faint green, is representing low malaria transmission. While the green, the totally green, as you can see, some part of the region like Arusha represents the very low malaria burden in the country. So in Tanzania, we always call that malaria has been divided into two cycles. There is northwest and south and southern part of Tanzania. So at the middle, we do call it a central corridor. Means there is always a low transmission malaria. So this kind of assessments has been conducted throughout the country and all regions, including all facilities via extracting the data from the DHIS2 within these 5 years, and make up a total of over 6,000 health facilities. And we actually, beyond the other factor, we wanted to see what is exactly the performance of this ANC and the EPI in terms of delivering ITN to the community or to the beneficiaries. So what we did, our aim is every infant and every pregnant woman at the health facility, at the first visit is eligible for ITNs. So all facility with provided ITNs for these beneficiaries, we term them a good performer. And while the less either do not provide the ITN, it is expected that the ITN were available at this time point were termed as a poor performer. And we did just analysis, just a descriptive, but some inferential statistics to come up, and we did just across time, these 5 years, and also across these 26 regions in Tanzania, and over 184 councils. These are subunity, subnation levels. But also we did cross against facility level. When I say facility level, I mean from hospital, health center, we have dispensary, and also categorize the final as the clinics. But also we did cross against ownership of the facility. Since I said this program is run throughout all facility in Tanzania, it means private and public. But also we did cross against a setting, rural, urban, to see the performance vis-a-vis the facility allocated in rural or in the urban. But also across the malaria transmission, these 4 epidemiological malaria transmission strata, we did use R for analysis, and we did a generalized estimation equations to model. We model them separately. And this is just a snapshot of the results. There was a general trend of ANC and the EPI performance or insulin length increased from January 2018 to December 2022. As you can see on the graph, the red color graph showing the ANC performance. It actually started, as you can see, very below. However, over these 5 years, the ANC was generally higher compared to the EPI. As one of our previous presenters also highlighted that the EPI sometimes are not perform better, and he also tried to mention some of the factors might be the reason why EPI are not really performing better compared to ANC in terms of item deliveries. But generally across the regions, most of regions performed, the performance increased remarkably. From the first year it was a really increase, but gradually it started increasing and they have some not a really steep increase. But Ruvuma is one of the regions that was really performing better compared to one of our major cities in Tanzania called Dar es Salaam, also performed the lower. While we did the performance also, as I said, is varying between ANC and the EPI over these 5 years. But in terms of performance, for example, for ANC in 2018, as we see, the graph started around 40%, and it went up to 93% in 2022 over around December. While the the EPI started at 34 and went up to 80%. And this one, the average issuing rate of performance was statistically significant. And moreover, it was an expected result that rural areas had higher performance. It means that the rural located facility in general performed better. It's like 72% over the urban area. You see now, you can imagine why rural are performing better compared to urban. Why you know that urban sometimes because these facilities are near to the people, but in the rural, for our study, really it was performing better compared to the urban. But across the epidemiological strata, this is a good result because the higher, moderate, and at least very low performed epidemiological strata performed better compared to the moderate, to the low. And it was also significantly. But for the health facility level, the lower level, which we term as a dispensary, performed better in both ANC and the EPI compared to Eiza Hospital. So this is another trick maybe for SBCC to see how better we really, does it mean the health provider from dispensary are really listening more, or we need to do more of maybe quality to see what are really other reasons behind why a dispensary level that really performing better. Is it the issue of documentation, the rest? Yeah, and also of the, regarding the public and the private health facility, from this graph, the dotted line means private facility, while the public facility with the full lines. However, the red color indicating ANC, and the blue color, I think it's the blue color, indicating the EPI. Generally, you can see that both ANC and the EPI for the public over these 5 years performed better compared to the private regarding the ANC and the EPI. For example, for the public, ANC it started around 52% up to 95%, while the ANC for private started around 10%, as you can see from the graph, and it went up to 83%. The same thing for the EPI for the public started around 40% and went up to 83%. And the EPI for the private or non-public started around 6% to 63%. Really, there is an increase. However, we see we need more strong emphasis for the non-public. And actually, because in Tanzania, it's around 32% coverage of the facility are non-public, so it's really changing, but majority are the public, but we really also controlled during our analysis. In discussion and conclusion, we see there was a substantial improvement of item performance over these 5 years from 2018 to 2022. But as I said, also the increase of performance over 5 years, both for ANC and the EPI, it was rise rapidly in 2018, but it went a gradual improvement and reaching the 93 for ANC and 80 for EPI respectively. However, we need more effort to achieve our main NMCP target that every woman attending for ANC need to be issued with an item, the same thing for infant. Because we really even try to dig down to see the availabilities. Almost every facility had the item by this time. Because, you know, for us in Tanzania, we use the medical store department already integrated with the government structure. Whatever the commodity, other commodity, malaria commodity are being supplied to the facility, the same thing, the items being supplied. So we don't see these kind of maybe difficulty in how to reach the item to the facility level, because every 2 months as the MSD do deliver directly the item to the facility as the other commodity related. So that's another observation for us. Probably we need further study, especially to the qualitative one, to understand what are the other variable factor influence this improvement or hinder those reasons. Just in case of discussion, like other studies show the other reason related to low or and the high performance of the ANC and the EPI. And a few recommendations: mentorship and orientation should continue into our team, because you always have some turnover, maybe people retired, some people move from one facility to another. A new employee, we need actually mentorship and orientation. And the good thing for us now, we always have the integrated the supervision. Whenever we go for malaria supervision in Tanzania, we always try to, if we are going for commodity-wise, also ITN is a parcel. We integrated our supervision to other supervision checklist, so that to make also part of it when you do a spot checking. We do also continue with data review meetings with our health facility in charges using Zoom meeting and the rest. But a further study, as I said, should be conducted for more detail. Just a snapshot. I really thank everybody, including the AMP, RBM, and the RACI for their contribution. Asanteni sana.
Thank you very much, Peter, for your nice presentation. Now we will move on to the next presentation. We will be moving around a bit in French as the next presentation will be in French. Je voudrais donc à cet effet inviter Marcel qui se chargera de nous faire la présentation sur le CAR, l'expérience de la phase pilote de la distribution scolaire de moustiquaires pour la mise à échelle. Monsieur Marcel, merci de prendre la parole pour votre présentation.
Merci pour l'introduction. On m'appelle Marcel Lama. Je suis conseiller technique au service de lutte contre le paludisme de la République centrafricaine. Je vais faire cette présentation au nom du coordinateur, le docteur Pascal Bakamba, qui n'a pas pu être avec nous ici. Et je voudrais dire aussi que je suis avec deux collègues, des PR du Fonds mondial, Aïe et Patrick, qui sont dans la salle et qui vont certainement nous aider dans les discussions futures. Donc, je vais essayer de partager l'expérience de la République centrafricaine de la distribution de moustiquaires dans les écoles et qu'est-ce que nous avons planifié de faire plus tard. J'en profite pour préciser que cette activité a été soutenue très fortement par le Fonds mondial avec les deux PR qui sont représentés dans la salle ici. Très brièvement, voilà ce que nous allons dire. On va parler un peu du contexte, quels sont les objectifs, la mise en œuvre, quels sont les résultats que nous avons obtenus et essentiellement les prochaines étapes. Pour ceux qui ne connaissent pas bien la République centrafricaine et qui se posent la question pourquoi le pays s'appelle République centrafricaine, en regardant la carte, je crois que vous devez avoir une bonne réponse. La République centrafricaine est un pays endémique du paludisme, avec une très haute et stable transmission à travers le pays. Et comme vous voyez sur le graphique, c'est la première cause de morbidité et de mortalité. En ce qui concerne la couverture... Can we remove these things? Ouais, en tout cas... Ah, mais ça apparaît bien là-bas. OK. Ici, c'est une revue de la couverture en moustiquaires imprégnés dans le pays depuis 2010 jusqu'en 2019 où on a eu les dernières enquêtes au niveau des ménages. Et vous vous rendez compte que le pays n'a jamais dépassé la couverture de 60% d'utilisation des moustiquaires. Et c'est une des raisons, le programme a commencé à réfléchir quelles sont les raisons et quelles sont les approches que nous pouvons utiliser pour améliorer la couverture. Nous avons utilisé des données de différentes sources, y compris les données nationales, mais essentiellement les données de l'OMS. Comme vous le savez, après, entre deux campagnes, nous perdons beaucoup de moustiquaires, de l'ordre de 8% la première année, 20% et 50%, essentiellement par détérioration physique, n'est-ce pas, et certains moustiquaires qui disparaissent du ménage pour avoir été cédés à d'autres parents. Mais aussi l'efficacité chimique se perd. Et donc, sur cette base, tout le monde le sait ici, que l'OMS a fortement recommandé que pour garantir une couverture universelle, les pays doivent appliquer une stratégie associant des distributions de masse et des distributions continues gratuites. Et donc, les canaux qui ont été recommandés, c'est les consultations prénatales, tout le monde le sait, les écoles et les distributions communautaires. Dans cette expérience, nous allons parler essentiellement de ce qui a été fait dans les écoles. Je voudrais préciser aussi que le Fonds mondial a accepté de financer une expérience de distribution communautaire qui n'est pas encore mise en œuvre. Alors, nous avons fait une revue des données Comme je disais tout à l'heure, en rétrospective, et comme vous le voyez ici, dans le mix 2019, on s'est rendu compte que les enfants de 5 à 14 ans, qui sont les enfants d'âge scolaire, sont les enfants les moins couverts par les moustiquaires. Et ceci se reflète aussi dans le MAS de 2016. Nous avons aussi les données de 2010 qui montrent exactement les mêmes problèmes. Les enfants d'âge scolaire sont généralement très peu couverts par toutes les interventions. Et nous avons remarqué la même chose aussi pour la prise en charge. Mais ici, nous mettons l'accent sur l'utilisation des moustiquaires. Alors, si on regarde la pyramide des âges en République centrafricaine, on se rend compte que les enfants d'âge scolaire représentent 32% de la population, un tiers de la population. Et si ce tiers-là n'est pas bien couvert par les interventions, évidemment, ils vont tirer la couverture vers le bas. Et aussi, en consultant la documentation, l'OMS recommande que pour que la distribution dans les écoles soit efficace, il faut que le taux de scolarisation dans le pays soit entre 50 et 80%. Et nous avons la chance qu'en République centrafricaine, d'après l'UNESCO, en ce qui concerne l'école primaire, le taux de scolarisation est à 87%. Et le MAS, le mix plutôt de 2019, a trouvé un taux de scolarisation de 72%. Et ça nous a encouragé à nous orienter vers la distribution dans les écoles. Et nous savons aussi que les couvertures par les écoles dans le pays, la couverture est largement supérieure à la couverture des systèmes de santé. En prenant l'exemple des données que nous avons en 2021, il y avait 3150 écoles contre 1024 formations sanitaires, n'est-ce pas? Alors, quels sont les avantages qui nous a, en plus des données que nous avons, qui nous ont encouragés à utiliser spécifiquement la distribution dans les écoles? Vous le savez tous, avec les écoles, nous n'avons pas à courir derrière les ménages, à chercher les gens. Ils sont regroupés toute la journée à un endroit, c'est-à-dire à l'école, et ils sont faciles à retrouver. Donc, on dépense très peu pour les rechercher, n'est-ce pas? Et les écoles avec les communautés, comme je l'ai dit tout à l'heure, ont une meilleure couverture que les formations sanitaires. Les enseignants sont des gens très respectés dans leur communauté en général, n'est-ce pas? Avec qui ils ont de bonnes relations, et souvent sur le long terme. Et donc, on peut les utiliser non seulement pour la distribution des moustiquaires, mais aussi pour la promotion des activités de santé. Les écoles aussi nous permettent de réduire le coût en termes le coût de la logistique, notamment le stockage, parce qu'on stocke les moustiquaires dans les écoles pour une très courte durée, n'est-ce pas? Dans notre expérience, on s'efforce pour ne pas dépasser 3 à 4 jours de stockage dans les écoles, et ça nous permet de réduire tous ces coûts-là. En plus, comme vous le savez, les écoles sont beaucoup mieux organisées que les formations sanitaires. Ils ont des registres qui sont à jour, donc on n'a pas de dénombrement à faire. Encore une fois de plus, ça nous réduit les coûts de la distribution de moustiquaires. Et ce faisant, nous utilisons les enfants comme des agents de promotion de la santé dans leur famille et dans leur communauté. Nous avons aussi regardé, parce qu'une de nos préoccupations, c'est, vous connaissez certainement que la République centrafricaine, c'est un des pays les plus pauvres de la planète. Et non seulement on est pauvre, mais les ressources vont en s'amoindrissant. Et donc, nous devons réfléchir très vite pour voir dans quelle mesure nous pouvons parer à cette réduction des ressources. Et donc, nous avons glané un peu les informations. Je remercie mon ami tout à l'heure là qui a parlé de la Tanzanie. Nous avons trouvé que la Tanzanie a fait une très bonne étude sur le coût-efficacité de la distribution des moustiquaires. Et nous avons eu aussi la chance d'avoir fait la même expérience en RDC. J'en profite pour remercier mes amis de la RDC qui sont là, en particulier le professeur Joris, qui nous a supervisé pendant ce travail. Et vous allez remarquer que le coût-efficacité de la distribution dans les écoles est au minimum, sinon inférieur coût-efficacité de la distribution dans les formations sanitaires pour les raisons qu'on a qu'on a dit tout à l'heure. Et en particulier, le coût par personne protégée si vous distribuez plus de environ 3 millions de moustiquaires, le coût par personne protégée tombe à 600 cents, 600 cents de dollars. Et je pense que pour nous, un pays pauvre, ça c'est très important. Et même le coût par moustiquaire distribué, le coût économique, revient très faible quand on fait la distribution à travers les écoles. Et l'expérience qu'on a faite en RDC a démontré exactement la même chose qui a été faite en Tanzanie. Et donc, sur cette base, le pays a décidé de commencer l'expérience de distribution de moustiquaires dans les écoles, avec les objectifs, bien sûr, de rattraper les pertes. Comme tout le monde le sait, entre les campagnes, les moustiquaires se perdent. D'améliorer spécifiquement la couverture des enfants scolarisés, mais aussi de réduire le coût de la distribution des moustiquaires, pour nous permettre de faire des économies compte tenu du contexte actuel. Et nous sommes très contents d'avoir constaté que nos inquiétudes se sont prouvées tellement vraies depuis le 20 janvier 2025. Alors pour cela, évidemment, c'est une stratégie qui n'était pas dans les documents nationaux avant, donc il a fallu réviser notre plan stratégique pour introduire la distribution dans les écoles, réviser les documents normatifs, et ceci a été fait concomitamment quand on faisait la subvention au Fonds mondial pour le GC7. Et donc, ces documents ont introduit la distribution dans les écoles, mais aussi, comme je disais tout à l'heure, la distribution communautaire et d'autres interventions que le pays a adoptées. Et donc, c'est comme ça que le plaidoyer a été fait auprès de différentes institutions, notamment le CCM et les structures nationales pour financer la distribution dans les écoles. Et je voudrais préciser que pendant la revue de notre proposition, le TRP a fait vraiment une remarque très intéressante et très encourageante en nous félicitant d'avoir adopté cette stratégie et surtout d'avoir utilisé des données pour les justifier. Nous avons aussi engagé des plaidoyers avec d'autres partenaires, notamment l'UNICEF, qui nous appuie aussi dans cette intervention. Alors donc, après l'approbation du Fonds mondial, après l'approbation au niveau du pays, la mise en œuvre a commencé, mais on voudrait rapidement faire le point. Bien sûr, la distribution est gratuite, n'est-ce pas? Comme nous voulons voir dans quelle mesure nous pouvons pallier à la distribution de masse. C'est une distribution annuelle que nous efforçons à tout prix de faire avant la saison des pluies et aussi avant la fermeture des écoles. Les écoles ferment en Centrafrique en juin et la saison des pluies, c'est la même période, avec un accent particulier sur le fondamental 1, c'est-à-dire c'est les écoles primaires, et nous donnons les moustiquaires aux classes impaires, n'est-ce pas? C'est le CI, le CE1 et le CM1 à raison d'une moustiquaire par élève, mais aussi nous donnons les moustiquaires aux enseignants.
ITN students, and also we give one ITN to the teacher. The distribution, it is done once. It is once a day, but it is up to the school to choose the day that we will move in and do the distribution. Later on, you will see the human resources that we had to consider in order to conduct that. So, for instance, for the student, for some who are either sick, we give them 3 days time to come and collect the ITN. So we conducted pilot activities. We came up by revising data. These are the latest data that we have at hand. and then help us also to show that health district with the lowest cases of ITN.
de scolarité les plus élevés.
2 and 3. And those regions also are characterized by a high level of children going to school. So, and one of the reasons also, it's one of the regions that's very close to the capital. Therefore, it will facilitate any oversight activities. The experience that we had last year and this year, now we are able to move to the second region, and God willing, next year we will add the third region and move progressively and cover the whole country about the school distribution. So an official launch was done. That was during the World Day of malaria control. So it was conducted and done, and also with the support of the head of state, as you can see in the picture. So the implementation after the launch, we come up with a planning, so which is not really different from mass campaign. We ended up conducting a planning at the district level, and we were able at least to identify the 462 schools. Among these 462 schools, we had 17,000 teachers. So, so we had an idea about the number of students that we were supposed to cover. So we needed at least 120,000 ITN, and it was done with the support of the World Vision, that is PI. As you can see, the outcome in terms of human resources used for this campaign, and also the staff from the education system, which is 150, and you can have also agent or people working in the health sector, that is only 5%. And for the school structure, we have a total of 150 people. As I told you in the beginning, we were able to identify 460 schools, and during the distribution, we've covered 465 because some schools were discovered when we were doing the distribution exercise. So in relation to the eligible students, we had at least more than 117,000, and during the distribution, 110,000 were able to benefit from the ITN. As we said, a total of 160,000 of ITN were distributed. And I would like to also emphasize that during this campaign, the country team from the World Fund was there, and they were part of these activities of ITN distribution. What was the challenge? The main challenge, of course, because in a country like ours, 625,000 square meter for covering 6 million of inhabitants, Mathieu, who is here, can in fact add on what I'm saying. We had a serious logistic issue. However, allow me to say, we also had issue about the conflict that our country is facing, as well as our schools were about to close. Some of them closed already. So I think these are the challenges that we had to overcome. So we also realized that despite all the sensitization, some of the people on the ground did not have the right information, and this is something that we need to take into account. We thought that in all schools we will find space in order to store the ITN. That was not always the case, so we didn't have the time to go and to visit school and to find out if they had facilities for the ITN storage. So we have parents. Parents are complaining, saying that these ITN should be given to everyone. But we had to explain that the durability of the ITN, it is 2 years. And sometimes some private schools are reluctant to sharing more information. So one of our main issue is to assess what we are doing. Sometimes we have money to conduct activities, but less to conduct assessment. What are the lessons learned? Of course, we need to have a good planning. Actors must understand it, especially those who are working in the school sector. And we need to know that these activities take time, especially in terms of budgeting, and pick those who have experience in mass campaign. So just a small summary with regard to the way forward. As I said before, we are going to add the second region, and next year the third region. So this is the plan that we have to do so that we may start distribution from the month of May and covering region 1 and 2. And that we also plan to take advantage of the relationship that we have with school and put some site that we call a malaria point. And we believe that very well trained teachers will be taking care of those centers. So this is the end of my presentation. And I believe that with these experience distribution from schools, it is a very big opportunity, especially where resources are getting scarce and very quickly and sometimes very brutally. So I will believe that we can seize this opportunity in order to improve the covering through children, but we know that the ITN will find their way in different households. Thank you.
Merci beaucoup, Monsieur Marcel, pour votre brillante présentation. Nous allons à présent prendre quelques questions sur les deux présentations, celle de Peter et celle donc de Marcel. Et donc, avec le temps, nous allons prendre 3 présentations et voir si on peut gérer le reste. Donc, micro à l'audience pour les questions. Mic for the audience, please. Oui, allez-y, s'il vous plaît.
Juste une question pour Marcel, pour la Centrafrique. Est-ce qu'il y avait parce que
I think this is complementing national distribution, the national campaign. While there are double distributions in some households, how did you do a school distribution vis-a-vis a household distribution? Was it being done in parallel? Were there households which have less children that you could cover as well? I'd like to know if you took into consideration this. Thank you very much. In any case, the presentation was very interesting. We can respond that. Well, thank you. This is a very interesting question. First of all, I'd like to refer myself to the WHO's recommendation, which says that distribution, the catch-up distribution should be continuous before, during, and after mass distribution. So there is no double distribution is not a risk in any case. So this is from the point of view of the WHO. The more we increase the number of mosquito nets in communities, the more the communities are protected. So we are doing these campaigns each and every 3 years, as you know it, and the distribution in schools is continuous each and every year, even in years where we have no mass campaigns. It is the same thing when it comes to CPN and APIs. And I'd like to take advantage to talk about Tanzania, which did a very good presentation before us. In Central African Republic, coverage, the IPI coverage and NC combined is maybe around 30% only. And even if it is 100% coverage, it will only cover 8% of the population. So it is very, very important to combine all the various interventions. Okay. Well, thank you very much. You have the floor, please.
My question goes to the presenter from Tanzania. And during your presentation on the result of the study you conducted on the distribution, you described you indicated the performance in the rural areas were better than those in the urban areas, and you described that as surprising. And to me, that description is surprising. So I would want to learn, maybe if you can explain why in Tanzania you think the distribution, the high performance of uptake of ITN among rural areas being better than urban areas is surprising. Thank you very much.
Ok, merci. Peter, vous pouvez aller directement, s'il vous plaît. Ok.
Thank you. Yeah, that's what they're finding, but we can predict that in Tanzania, networking, especially to the rural areas, even in his facilities, are evenly distributed. Very few regions which may be in the rural, you can find the facility are less. We can't deny we are Africa, but also we can say in urban, sometimes his providers are very busy with other stuffs, probably in terms of documentation, the rest that I can comment. That's what they're finding. Thank you.
Thank you, Peter. Yes, please.
My question is to my neighbor in Tanzania. We, as Uganda, we have learned a lot from Tanzania on the routine distribution channels, including the school. But I wanted us to just for you to give us more light, considering the good performance of EPI and the ANC as part of their facility channels. Did you consider the overall reporting rate? Because it has a direct effect on your coverage by looking at what was the overall facility reporting rate. Then two, do you appreciate that availability of nets in your country for manufacture is a big drive to have the good coverage? Then if yes, we need to document it, because in Uganda we have had almost a 1 year loss to have the routine nets available in the country, compromising the performance of our routine distribution coverage. That's why the campaigns have remained a priority. Thank you.
Thank you. Peter.
Thank you so much for the good question from my friend Medad from Uganda. Actually, on our study, the reporting rate we did, it was around 89.7, like, for both ANC and the EPI. And what we need to note, these children or infants, they do not come alone at the facility. They come with this care giver or parents. But notably that we can find that in urban settings, sometimes which you haven't asked a question, there was a kind of experience which we just observed, though was not in the study. Some infants are brought at his facility for aiming for vaccinations, but they are being brought by this called the boda man. Eh? So they are in a hurry. So sometimes even those kind of how to take or to have the net, it was kind of a challenge. But this was kind of observation. But for the second question that the manufacturer might be the drivers, we can say yes, but not direct, because the items we do procure, as the other country, we place order like 6 to 8 months prior. And then we have our logistics, the medical store department always be there at the zones levels. We have almost 10 medical zones, which at least every zones do save like 3 to 4 regions. Actually, before even having a stock out at the facility, they always have the order request and the reporting and the request, R&R, they do request at resupply management. But what we can also mention that we have our annual Zoom meeting for within charges also to remind in different items related to malaria. It might be also the reason that maybe we always have this kind of full supply of item to the facilities. Yeah, this I can comment in a few.
Okay, thank you, Peter. I have one question for Marcel. Marcel, par rapport à la distribution scolaire, je voudrais vous demander si c'est les enseignants seulement qui sont mis à contribution de la distribution ou vous faites recours à des agents externes. Est-ce que vous remettez seulement les moustiquaires aux enseignants, ce qui serait d'ailleurs plus facile et moins coûteux, ou bien vous impliquez des agents externes? Et l'autre question, j'ai vu les enfants avec des moustiquaires en emballage individuel. Est-ce que vous les laissez rentrer avec les moustiquaires emballés? Et comment vous gérez les déchets issus de la distribution scolaire? Et pour finir, si vous pouvez nous dire brièvement, est-ce que vous profitez de cette occasion pour faire de la sensibilisation, associer les enseignants par exemple pour des cours de sensibilisation en faveur de la bonne utilisation des moustiquaires? Merci.
Je peux? Oui, merci pour ces questions. Je pense que c'est des questions qui nous trottent dans la tête et qui nous permettent de réfléchir constamment.
Forces us to reflect constantly in order to see how we can improve. As you saw in the presentation, the human resources that we used, 85% were made up of teachers. Distributors are teachers, which means that during this process, we train people at the level of health regions. We also teach teachers who are in charge of distribution in their own schools, because teachers do the distribution. So the high-level personnel, especially from health districts, who are made up of health officials, they do supervision, but distribution is done by teachers in their own classes. And as the presentation said it, during the distribution, we talk to teachers about malaria in general, its prevention and also treatment, with the objective which is clearly defined, which means that they should ensure that malaria is part of courses given in school. As you know, in school system, there is a week, 1 hour a week, where we talk about health. So we encourage them to ensure that malaria is regularly part of this course for children. But you also know, teachers, as we told you in the presentation, they have a lot more authority within their communities, and so we use them as promoters of health. the relation that we have created with the education system, we think that it is very profitable for health in general, but especially when it comes to dealing with malaria, given that you can see the coverage of the health system is a little bit poorer vis-a-vis the education system coverage. So we have teachers everywhere, vis-a-vis the health system where we don't have workers everywhere. So in any case, we are discussing with the community involvement program in order for them to consider teachers as part of community health workers, because they have an advantage. They are more learned than some community agent or community health workers, and they are learned. They have more authorities, and so we take 1 week to train them, and I think that it is sufficient. When it comes to the issue of packaging in guidelines, first of all, you have to remove the mosquito net from its packaging in order to give it to students. But sometimes on the ground, there are some deviations and which should be corrected, but the directives are very clear. You have to remove the net from its packaging in order to give it to the students. So these are some of the responses that I can give when it comes
Merci
to
à
your
vous pour les
question.
réponses
Thank you
apportées.
very much
On
to
est
your
dans le temps
responses.
et donc nous allons continuer avec la dernière présentation de ce matin qui sera celle de Monsieur Madi Sissoko, qui va nous présenter la distribution des moustiquaires en communauté, Cap du Nord, Mali, en 2024. Monsieur Sissoko, à vous.
Okay. Bonjour tout le monde. Je m'appelle Dr Madi Sissoko. J'ai l'honneur de partager l'expérience du Mali sur la distribution communautaire des moustiquaires imprégnés d'insecticides dans un contexte d'insécurité qui concerne le nord du Mali. Donc, l'équipe du Mali est composée de la directrice du programme national de lutte contre le paludisme, le partenaire qui est le PR de la subvention du Fonds mondial et moi-même chargé de prévention. Donc, pour le plan de présentation, nous allons faire l'introduction et une analyse sécuritaire qui nous a permis d'assurer cette mise en œuvre.
Do this implementation. There are some aspects to do with planning, the various approaches.
Le paiement, les résultats issus de la campagne, les quelques leçons apprises que nous avons jugées utiles à partager, les recommandations, les défis et la conclusion. Donc pour parler du contexte, nous savons que la moustiquaire RS aujourd'hui
Nets are one of the major interventions, as it was said yesterday by the WHO. So this is an efficient intervention, around 80%.
L'utilisation par les populations afin de se prévenir. Les principales sources d'approvisionnement sont les campagnes de masse et la distribution de routine, même si au Mali nous utilisons d'autres canaux qui sont non moins importants, les distributions dans les orphelinats et les sites de déplacés. Ces résultats sont ceux de la dernière enquête démographique et de santé 2023-2024. En 2023, le Mali a planifié une campagne de distribution nationale dans l'ensemble de ses districts sanitaires, excepté la zone urbaine de Bamako, en 2 phases pour des raisons stratégiques et logistiques. Nous avons pu réaliser la première phase dans 5 régions qui a permis de couvrir environ 22 millions d'habitants et 10 millions de moustiquaires ont été distribués. Par contre, pour la seconde phase qui était prévue en novembre 2024, n'a pas pu se tenir compte tenu de la dégradation de la situation sécuritaire. Face aux besoins quand même de poursuivre cette distribution à des populations vulnérables à cause de la faible transmission et du risque des flambées épidémiques, des déplacés des populations liées à la situation sécuritaire, le Comité national de coordination de la dite campagne avait mandaté le PNLP de s'appuyer sur les différents partenaires techniques et financiers, notamment le Fonds mondial, le PIAR qui est CRS, de pouvoir élaborer des directives adaptées pour que les moustiquaires puissent être distribués dans les régions concernées malgré l'insécurité. Donc pour cela, nous avons dans un premier temps procédé à une analyse sécuritaire qui a porté sur 3 volets. Le premier consistait à faire la disponibilité du service de santé à travers l'existence du personnel, les moyens de communication, un mécanisme d'approvisionnement pour pouvoir assurer l'activité. Pour ce qui est du volet...
So when it comes to security issues, we worked with state organs, mostly OCHA, in order to categorize the various health districts and health areas into 3 levels: light security risk, moderate security risks, and critical risks. And this was able to be done, and this allowed us to come up with this classification. And we have 15 health districts where continuity of health service was well, and the security risk was light, and we were able to also have moderate services, and there are areas where there were no staff, so we needed to mobilize mobile teams in order to push forward with this service, despite the fact that security issues were critical. And lastly, we looked at areas where these risks were critical. So you can see from this map, there are the 15 health districts, and in red, we have health districts which where we could not launch our activities. So when it comes to planning, was based on the recommendations of the Alliance for Malaria Prevention. We used the populations projected in 2024, which means that for this, the population used for this campaign was from 2009 census. And as you know, we were not able to organize our campaign in 2023, and we did some planning in order to take into consideration the population growth, and this campaign was only done in 2024. In terms of coordination, we came up with a committee, a high-level committee. So we had the Central Committee, which was under the responsibility of the Ministry of Health, including the Secretary General in the Ministry of Health. In regions, we had the governors who ensured coordination, and in districts, we had the district prefects. When it comes to micro-planning, we were able to adapt ourselves to the context. Also, the first 15 health districts, which had an acceptable level of security for continued distribution, we organized virtual meetings with directly with the regional teams, and we used classic campaigns in order to ensure that we were able to reach beneficiary in health districts. And so districts were not able to meet together in order to organize these workshops. That's why for the first time we organized the virtual meetings with health districts that had the means to do it, in order for us to use Zoom and other platforms for meeting. And further, we did some training on micro-planning tool, and we sent them the templates, and they were able to communicate and share data and information. And this was done up to 2 months in order to collect information from health districts in order to complete our templates. And this was consolidated during a training session which was organized in Bamako for 5 days, and we took advantage of this in order to train regional teams about the directives for community distribution. And afterwards, we came up with with the calendar for the campaign that was to be carried out, depending on the evolution of the security situation. And there were some activities which were planned, and afterwards, the regions took leadership of the campaign in order to continue with the trainings in districts and also sharing microplans and data. So for areas where security issues were critical, we did the same thing. We organized a virtual meeting for training, but it was not possible for these teams to come to Bamako for the physical meeting, for the physical training session. And so we were happy to just limit ourselves to virtual meetings in order to strengthen their capacities. And we also shared our template with them in order for them to fill it and share our strategy and each and every approach that we had. And there were also guidelines for the campaign. Thank you very much.
Recording in progress.
So for the various approaches, the 15 held districts where the security situation was stable, was relatively stable, we adopted the following strategy. There were household, village, and health area census under the supervision of the director of health districts. And for census, we had community health. Instead of using community health workers, we used community leaders and councillors who had some books, and they were able to register households as well as the number of people in this household given the size of the villages. And so we had 2 or 3 officials who are in charge of these census, and once the census done, they were presenting this information to the heads of villages who organized a meeting for the village council in order to validate the data which was shared with the health services. And based on this, we distributed mosquito nets, and redeployment was necessary given the situation of insecurity which led to displacement of certain people within villages. So we did some redeployment in order to adjust ourselves, and afterwards there was distribution which was organized with the same community actors. For districts where the security situation was critical, we adapted ourselves based on case from case. The Kidal region, which has 4 health districts. First of all, we continued to collect security information at various levels, including health areas, and up to today, these 2 districts have not been censored very well, and so we used mobile teams which went into communities, and they were counting the number. They were doing the census while distributing at the same time. But these 2 districts, they continue to be under critical security situation. So, but for Menaka, the security situation means that all health districts were brought together within the capital, the regional capital.
Recording in
and
progress.
Afterwards, we had access to resources for social development, social and development departments, which allowed us to estimate the number of households which are faced by the various issues of displacement. And afterwards, we organized a campaign in this region using the 2009 data, while adjusting it in order to distribute mosquito nets. When it comes to transportation of mosquito nets, we were working in difficult areas, so we used the World Food Program, which has a lot of experience in transporting goods in areas where there are insecurity issues. So the World Food Program, WFP, helped us a lot. And local actors were also contributed to transportation, especially workers within the health districts, humanitarian workers as well as associations within some of these communities. When it comes to the results, we were able to ensure distribution of 4.9%, and distribution was around, coverage was around 99.699%. So during distribution, some displaced people were more vis-à-vis what we had planned for. When it comes to payment, we said that this was adapted to the security situation. This
Recording
was
in
based on the
progress.
availability of telephone network because we did it. This was around 40% cash and 60% mobile money. So this was for the various actors who are involved. And as you can see, transportation started in July, so the census started in September, and distribution was done in November and December for some of these localities. Next slide. So at the end of this campaign, we had a number of lessons learned. The first one was the issue of a permanent support system, despite the security situation, which allowed them to understand the tools which were new for them, but they were able to master them in order to carry out this campaign and share data regularly with us in order for us to ensure that we could analyze the security situation in order to carry out the campaign. And today we have been able to carry out this campaign without any major incidents. When it comes to the transportation, we would like to tell you that we took a lot of time when it comes to the delivery of mosquito nets from Bamako to the various health districts, which had an impact for this on the start of the campaign, because in some regions they had been flooded and there were difficulties in accessing them. In terms of payment, we understand that the fact that we did not have a rapid payment mechanism for some areas where we do not have telephone coverage, this delayed our activities, and this had an impact on the start of the distribution activities. The census model involving community leaders helped to strengthen community participation and also facilitated data validation while ensuring credibility of the information that we were given. And we were surprised to have a lot of quality data from the households. The delay in the start of distribution until October 24 led to an increase in needs because the population were coming incessantly. Still on the issue of lessons learned, we would like to insist on the fact that collaborating with social services, which had a register of displaced people, allowed us to have a database for strengthening our planning for areas where there were displaced people. Another lesson learned is that during the campaign, within the same region, there were displaced people. There is a district that we call Asongo, which is the capital of a region called Gao. And here we had some difficulties because the population had not been censored, and with the support of the Regional Coordination Committee, we were able to integrate this community, and some supplementary nets were provided. And so these are some of the lessons that we learned. And upstream, we decided since 2023 to have some stock based on needs to cover up to 8 months of needs due to difficulties of access. So we had the routine stock as well as some stock to cover some gaps within this region. We had some difficulties, including availability of internet connection in some localities, and there is also limited geographical access in certain locations due to rising rivers and also flooding in some areas. And this stopped some of our activities in some health districts. The difficulties and challenges from these two campaigns. So we would like to use this lesson learned in order to better plan for the next campaign. So today we are thinking that timing between household census and distribution should be taken into consideration. The access to region is relevant, and in order to, we have to ensure that we have a new approach. But today we know what is efficient when it comes to distribution and use of nets, and how can we ensure that people use these nets which have been distributed. And during the request uh, for these grants, there are some 8 low transmission health districts which we have to take into consideration in 2026. And in order for the next campaign, we have to plan for these 8 health districts. So today we have to elaborate and respect the timetable for the 2026 campaign. We also have to take into consideration climate hazards when it comes to transportation of mosquito nets. We have to use channels which are adapted to continue raising awareness among the population on the use of mosquito nets. And we should also assess the coverage and of possession and use of mosquito nets, particularly distribution. So in order to wrap it up, despite the security situation which is worrying in the northern regions, the distribution based on the analysis of the functionality of health system and the level of security through reliable sources has allowed us to ensure satisfaction through a mass distribution, which has been efficient in some regions. So I'd like to thank all actors, Global Fund, PRS, communities, and technical support, which allowed us to have these results. Thank you very much, Mr. Sissoko. He respected the time was given. We have at least 9 minutes to ask and have responses for our questions vis-a-vis this presentation. You have the floor in case you have a question or a comment to make. Questions, please? Maybe I'm going to start if we don't have any questions from the floor. Thank you once again, Mr. Sissoko, for your brilliant presentation, for sharing the experience of Mali. At the end of the presentation, you said that you excluded 8 health districts which have low transmission, and this will be taken into consideration during the next planning. My question is this: what is the level of transmission in order for you to use it to exclude some zones, and what other protection measures have been put in place in these areas where you are not planning?
Peut-être ne répondez pas encore, on va prendre d'autres questions. Il y a des mains levées. Oui, question, s'il vous plaît. Oui, allez-y.
Oui, bonjour, merci beaucoup pour la présentation. Si j'ai bien compris, il y a...
If I understood it well, there are some areas in 2 regions where the security climate did not allow you to distribute mosquito nets, but are you planning that for the 2026 campaign, that if the situation improves, you are going to be able to distribute mosquito nets in these areas? Thank you. Can we talk? Can we give the floor to one more person before giving the floor to Sissoko? You have the floor.
I really appreciate it. I have a question on, you said you had very good results on the household registration done by the community leaders. So my question is, how were they been selected? Were they provided like tools and training? So Could you please share that lesson learned to see how did you approach the use of community leaders for the household registration? Over.
Okay, merci beaucoup.
Thank you.
Soko.
Thank you very much, Mr. Sissoko. You have the floor to respond to these 3 questions. You have the floor. Thank you very much. For the first question, effectively, we have around 75 health districts in Mali. For the first question, I'm saying that we have 75 health districts. We have a stratification is recommended by the WHO at various levels. High transmission, moderate transmission, weak transmission, and very weak transmission. And 25 districts have a high transmission, others moderate. There are others where transmission is low, and for those where transmission is very low, we excluded them completely from this campaign. For the 2023 campaign, the low distribution districts were included, but we had planned it, but we do not have enough resources, but we didn't have any choice, but we had to exclude these low transmission areas. So we used the analysis of our structure. We analyzed the distribution of malaria in order to prioritize areas where transmission was very high. And we also looked at the issue of operational costs. In a classic manner, excuse me, I was saying that the 2026 campaign was planned on based on the prioritization of the malaria risks, and this was done in 2009, and we reviewed it in 2023 when we asked for a grant from the Global Fund. And based on this stratification, we have 75 health districts, and 55 have high to moderate transmission, and these were the ones which were prioritized for the 2026 campaign. The 8 health districts, they were a part of the campaign, and given the fact that we have less resources, we have not been able to continue working in these districts, but we are trying to do advocacy to some partners, but recently our requests were not accepted, but we continue to do advocacy in order to be able to buy mosquito nets for these 8 health districts, including all the concerned districts. What alternative measures have we put in place beyond this campaign? We would like to continue routine distribution. We would like to strengthen routine distribution, targeting other target populations. So we are going to do distribution in schools, within communities, in order for us to strengthen distribution of CPN, as well as during vaccination campaigns. For the 2023 campaign, indeed, we had 2 districts in Kidal, which up to today have not had a distribution, but the mosquito nets are at the regional capital. But once the security situation is stable enough, we are going to distribute these mosquito nets. These are not huge quantities. They have been transported, they have been received by the region, but the security situation does not allow mobile teams to move around. And once the situation improves, we are going to do this distribution, and actors are going to be paid for the same. When it comes to community leaders, personally, we did not choose them, but there are councils and volunteers who are designated for this activity based on some criteria. These people were supposed to be literate, to know how to write and read, and they had to know how to write in a simple book, so they could create a list of 5 households, and they registered all households. And at the end, there was a meeting of the village council to validate all the data and to ensure that all heads of households had been registered in order to avoid conflicts. And these lists were shared with us in order for us to distribute mosquito nets. And once they were chosen, there was a training that was organized at the level of SESCOM. And this was done by health center leaders. And so they were trained on what information they were supposed to collect during the census and what information they were supposed to give in terms of sensitization. And when it comes to distribution, they were given some guidance within the regional capitals. And community actors were moving from one locality to another, but we were not able to do some training sessions. Thank you.
Thank you so much, Mr. Sissoko. It is 12:30, and according to the agenda, at 12:30, we need to go for our lunch break. So I would like to thank all of you as well as the speaker, and I want you to clap for yourself for that. And before going for lunch, I would like to remind you that we need to be back here by 1:45. So let's try to do our best to be here by 1:45. Thank you so much, and enjoy your lunch.
Dr. Wapo is going to be leading, the same session that Dr. Rock started this morning, which is operationalizing ITN access to operationalizing ITN distribution to optimize access. So I'll hand over to Dr. Wapo.
Thank you so much. Are we all in the room? Okay, so fine. Okay, I will call on the first three moderators, the first three presenters, Christine. Christian Atta Obeg, Herizo, and Joris. Please have a seat. Is Herizo here? Herizo from Madagascar. Joris from DRC. Please give it up for them. Okay. So Christian will be talking to us about the current malaria situation in Ghana. He will tell us about the campaign optimization, what was the rationale and the benefits for doing that. He will also tell us about the strategies that they use to combine the ITN and the PMD campaign. How did they integrate it? What were the challenges? And he will share with us the lessons learned. So, ladies and gentlemen, colleagues, let us put our hands together as we welcome Christian Atta Obeg to the podium.
Hello, good afternoon. Thank you. I had to quickly manage a gum or a toffee. So, 1 second. Right. So, this presentation is just to expand on our thinking on optimization. I think that the discussion on optimization has gone on, and we want to share the perspectives from Ghana. It's not new to us, the thinking about optimization, and we keep evolving with each campaign. So this will just highlight some of the things we have done and the thinking into the future. This will be the presentation outline. Go through the campaign optimization, the rationale behind it, ITN campaign, SMC campaign, PMD SMC integration, and then the challenges and the lessons learned. So Ghana, as you would know, we are currently, for those of you who have followed us, you realize that we are now NMEP. We used to be NMCP. It's not just by chance. We have actually transitioned in the way we think, and it's expected to reflect in the way we actually do things with activities. And with that, we actually saw a transition in the planning and the strategy that we use for campaigns. So we are currently implementing what we call a National Elimination Strategic Plan. In that strategic plan, we have 3 goals. And the 3 goals, the first one is that keeping 2022 figures as baseline, we would want to see 90% reduction in malaria mortality by 2028. We would also want to see a 50% reduction in the cases, and then we would also want to achieve pre-elimination in some 21 districts. And there are specific objectives. The one that relates to vector control is to ensure that 100% of the populace are actually protected by at least one preventative intervention. And we know vector control is a preventative intervention. So what's campaign optimization? I wouldn't go into the textbook definition, but the basic tenets of optimization is a continuous refinement of the strategies used in public health, and you'd also see that core to optimization is the maximization of impact and efficiency. And it's expected that when you do this, you get better with your outcomes, your engagement, and even you engage and collaborate well with your audience. So what's the rationale? Among many rationale, realize that with interventions, you are looking to do good. And to do good, you need to think about greater good, the numbers. So if you have a good intervention that is not scalable, it doesn't really help the masses. So you are thinking of being optimum in the use of your resources so that you can actually do good to many people through a scale-up campaign. One thing that you also realize is that the more you do something, just like the saying goes, practice makes perfect, you learn a lot from practice. The good, the bad, it actually shapes you in thinking outside the box. I mean, I'm struggling doing this with my campaign. Are there ways I could do it better? These are the things that actually bets thoughts for optimization. And now more than ever, I think the discussion has gone all well about limited funding, and if not for any reason, we know the constraints where we are in. We need to do good in the use of, I think I'll borrow someone's phrase from yesterday, do more with less. And I think this is the time we need to do more with less. What are the benefits? I mean, the dollar is there, cost savings. But there are other benefits that we rarely talk about, shortened campaigns. As a country, we are coming from a time where we used to do campaigns 2 years, sometimes 3 years. One campaign taking everybody's attention for 2 years, that's not worth it. We also see a reduced operational cost. We always talk about the dollar, and there's so much we spend on campaigns. I always ask this question. One day we wake up and we hear that the donor is only able to provide drugs for SMC, nothing more. We say no, we still have to get the drugs to beneficiaries, and that would mean erasing operational costs or being very optimal. These are some of the thinkings that we need to do. We also realize that the more you optimize, you become efficient at your campaign. It also reduces stress. Those of us who have been at the fore of campaigns, one of the things we always say is campaigns are difficult, and we all feel it. There's a lot of stress when you're doing campaigns, a lot of running around. Physically, you feel drained. Emotionally, you feel drained. Let's not even talk of the casualties. We rarely talk about the casualties, but personally, we have experienced 1 or 2 casualties, not entirely as a result of the campaign, but you could see it. There could be some nuances. Somebody rushing because they're under pressure, involved in an accident, totally avoidable. But these are all some of the things that come with campaigns. What are some of the practical examples of optimization for the country? Some of you are familiar with this. That's a picture of a code card. And This is something we did 2018. The picture down is showing you the code card requirements for just one district. Bear in mind, we have 235 districts that implement ITN mass campaign. So this is also one of the least populous districts. So just multiply this picture by 235, and this is just not going into the printing. You're also thinking of how you move this, among other logistics, to these districts. And when we did away with this, we saw a lot of cost savings, not only in the printing, but also in the transport of this. This is one example. We've also transitioned to what we popularly term BYOD, bring your own device. And this, just the background to this. So when we went paperless, we went electronic, and the electronic use was with a homegrown application. So in Ghana, we have developed our own application that we use. One of the IT managers who is responsible is actually in the session. We developed our own application we use for ITN campaigns, we use for larval source management, and also for SMC. So we transitioned from paper to electronic use, but the electronic use was via program supplied tablets, and that was huge in resources to procure the tablets and also to move the tablets. So you procure with huge sums of money. You also have to move them inter-regions with huge sums of money. What are the down costs? You have wear and tear. You will have to replace some are getting stolen, some are getting lost. You are struggling with having to hold on a campaign so that you finish and then move it to another. There's so many dynamics that come. Now we are implementing what we call the bring your own devices, and there has been so many improvements with the way we do our campaigns. Another way we have optimized our campaign is in supervision and monitoring. I have this that is showing a supervisor and an RA. An RA is we call a registration assistant. These are the volunteers in the communities that assist with the house-to-house registration. We have layers for supervision. There's a district supervisors, the regional supervisors, and the national supervisors. What we've seen is that the district supervisors are directly interfacing with the RA, supporting them directly. Previously, what we did was the regional and the national were also sort of duplicating the same monitoring strategies. Everybody is chasing the RA to monitor them and support them. This same RA also has targets. So why are we doing the same thing? What we did was that we are now doing what we call a rapid assessment. We use data to inform where there are real challenges, and we actually move in to solve problems. Where there are efficiencies or good work done, there's no point. You can actually learn from those places to other places. What did we do in savings? This actually saw us reducing by 50% the supervisory needs from region and national, and these are all huge cost savings. And then we also integrated ITN campaigns with SMC. What's the rationale? SMC, we know, together with ITNs, are all community-based, same households being bombarded. At one point, you are coming to me to ask for data on my children. At another point, you are coming to me to ask for data. Can't you, same health worker, can't you ask the same question, gather all the details, and then use it for what you want? And that's the basic rationale behind it. There are also overlaps or synergies in the campaigns, and when you do it together, you realize that one aspect strengthens the other, and obviously there are cost and time savings for implementing these campaigns together. ITNs, everybody around here knows what ITN distribution is and the channels. Just to highlight that as a country, we've been doing mass campaigns 5 times, beginning 2010. Today over lunch, I heard a colleague from Liberia saying they are doing door-to-door, and it just struck something with me because it brought memories of how challenging door-to-door was. That's like, are you doing door-to-door with all the challenges? Because I know it's difficult. We tried it once, and we've never done door-to-door. Now we do the point mass distribution every 3 years. We've done 5 of it, and the target changes. 2 years ago, we were targeting 90% of the population. You register them, you distribute to 90%. Now, in urban areas, the targets differ. We do between 40 to 90% to register them, and then we distribute to at least 90% that have been registered. SMC, if you are not familiar, just to give you a background, SMC is the intermittent distribution and dosing of children with sulfadoxine, pyrimethamine, and amodiaquine. And we do this at a time. So we do it just before the rains when the population is at most risk of getting malaria. And the idea is that it keeps therapeutic concentration of the drugs within them that lasts over the period. So we do this, we use climate, we use data to decide on when we want to do it, and we go into it. Two years ago, we were doing four cycles, but now we are doing 5 cycles. And all of it is actually with data. We are seeing that the rainy season is becoming longer, and so we need to adapt. This is just a picture for how, when we did integration, how it looked like. So some areas were doing only PMD, or point mass distribution, if you're not familiar. Some are doing SMC exclusive, and some are doing the mixture of SMC and PMD. And this is the outlook of how the integration was. So what are some of the guiding, I have something that is, all right, okay. What are the guiding principles? So the lessons from previous integration. We've done integration before. Actually saw on the participant list, David, I don't know if he's here. He helped us document our integration from 2018. So we did integration 2018 campaign. We didn't do 2021, 2024, we are doing integration. And there are a lot of learnings that you use to inform whether you do it again or you don't do it. Consultation, we realize, is very, very key when you want to integrate. One of the things that challenges we had from the 2018 integration was at the higher level, we had a plan. It was solid. We knew what we wanted to do. But what eluded us was that the planning is out there, but the implementation is actually down there. So you need to bring all the primary players up and up to speed in all your engagements so that they're actually on board. Now we've done things better. We engaged earlier and we are seeing the results. Integration any day is not easy, but it's easier when you consult, you work with people not only at the national level but at all levels. This is a flow chart or an outlook for how we face our campaigns. You have something similar for PMD, but when we integrate, we do this for the 2 campaigns. Essentially, we need to keep our eyes on phases of the campaign and the activities. PMD is such that so many things are going on. We need to keep your eyes on every activity. The success of one has ripple effects. The failure of one, so keep your eyes on all. You do all your pre-campaign activities. You're doing your estimates, which is very important in your micro planning and all. Your briefings, regional briefings and all. During the campaign phase, you're doing a lot of trainings. You're doing registration, dosing, M&E, monitoring and supervision. You're doing a lot of transportation of logistics and tools. Post-campaign, there are a lot of evaluations, reporting, reverse logistics, and all. You see SBC running through all the campaigns. This is telling you how pivotal communication is before, during, and after ensuring success of these campaigns. So what are the areas where we integrated? One thing you should know is that integration is good, but you are not likely to get everything integrated. For starters, PMD is very, very specific. Sorry, SMC is very, very specific. There's a time you do SMC. PMD, a bit flexible. I mean, you can give the nets at any time, but you want to be specific on when you are giving the drugs because you want it to be before. So what we do is that you keep the SMC timelines fixed, and then PMD rallies on. And that's one of the things that you need to do early on. So there's a lot of planning meetings, and one of the things we did that ensured our success is we held a week-long stakeholder consultation at the SMC regions, bringing all these players, week-long discussion on how we do this. Trainings were also integrated. We had this, the facilitators for trainings going through the training manuals. We actually integrated the training manuals for SMC and PMD, and then we used that. Registration was actually integrated in one cycle of PMD. I mentioned there are several cycles. So the registration is the one you go to the houses, and that's the one main aspect of the PMD we could actually integrate. Distribution phase is in the community, at a point in the community, so we couldn't integrate that. But registration was feasible to be integrated with one cycle of
SMC. Documentation and IT support was also integrated. Monitoring and supervision was also integrated. I'll give you an example. We used to do PMD in 5 days, SMC in 5 days. When we integrated, we did this in 7 days. 3 days savings on everything. And SMC, SPC, dosing and registration was also integrated. So this is just showing you the results for the campaign, just building on some confidence that integration does not affect the success of the individual campaigns. And this is just to tell you, we did very well in both campaigns. In SMC, the coverages are very high. In PMD, the coverages are also very, very high. So integration is possible, and it does not affect the results if you do it and do it well. What are the challenges? Relatively, you spend longer hours or time in trainings because you're integrating. As much as you'd want to keep it abridged, there will still be a lot to cover in the training sessions. A few volunteers complaining the workload are difficult. One of the things we did, learnings from the 2018 integration, is that you have more volunteer need for SMC than for PMD. And in 2018, we had the scope for volunteers being different and staggered. So some volunteers were doing only PMD, some volunteers were doing SMC and PMD. And it's reflected in their allowance being different, the time being different. And that's one of the downfalls for that 2018 integration. We have learned, and in 2024, what we did was that the targets were revised and everyone was doing integration. It wasn't some doing integration, some not doing. So there wasn't anything to compare with. And I think I've mentioned it time and time again, that the modalities, the messaging, the communications should be clear and well communicated from the start. We are also using an Android platform. A few of them complain that they don't have an Android platform. But again, when you engage them early, there's an aspect of registration we do before, which is array training. During this array training, we also do an assessment of the tablets. These are your personal tablets. I want to be sure that you are bringing us a good tablet that won't run battery down in the mid of registration. So we assess the tablets, they are good, and then we get them to use it. What are the lessons? Again, I've mentioned it. Prior consultation early is very, very important. Having different volunteers working different scope, I mentioned, does not help. I think the last point has been explained over and over. So the conclusion is that, more than ever, now we are in times where we have a lot more motivation to become optimum, to save monies, to do more. And we need to ensure we do that. And the benefits of optimization is not only in cost savings, I mentioned but a few. I personally feel that I look forward to a future where we are able to do campaigns in 5 months. Is it possible? Can we do campaigns in 5 months? Oh, I'm not seeing anyone. In Ghana, we've done it in 8 months before, and I think it's possible. It will help everyone. The focus is on other things. We've integrated COVID with PMD, COVID with vaccination. But when you're doing PMD, everyone is too focused on one thing, and sometimes at the neglect of other important things. You do it in a shorter time, the focus on other things are also taken care of. And the country should prioritize campaign optimization while we plan. So we have 2027 to plan for the next campaign. 3 years in advance. The thinking should start now in what we can optimize even before we go into this campaign. And that is where I would end and say a big thank you, acknowledging all the people who support us in doing this in the regions, in the communities, and then Global Fund, and shout out to USAID PMI, who are not here but are with us. And AMP for giving all the technical guidance. I was just saying over lunch how AMP has been strategically positioned to support countries. So thank you, AMP, and thank you all for listening.
Thank you so much for the presentation. And I think one takeaway for me was in his conclusion when he said that now is the time, more than ever before, to think about integration. Especially now with all the financial constraints, we should start thinking integration. We'll now call on Herazo from Madagascar to come and tell us about e-learning and what kind of quality it brought to the campaign. Thank you.
Merci beaucoup. Mesdames et messieurs, bonjour. Moi, donc, c'est Irzou, technicien au sein du PNLP de Madagascar. Donc,
in CMNP in Madagascar, we are the representative of our country in this meeting, and now I would like to share with you how the online learning has been done in order to improve the quality of insecticide-treated mosquito net in 2024. Normally, the digitalization also was taken into account. So this is the structure of my presentation. First of all, let's move to the context. After the context, we have the way forward and also the concept of tools, the result, challenges that we came across, as well as resolution, and finally recommendations. First of all, the training plan. Before our team came up with an action plan for the campaign. And then normally we have a training of 3 days, and this training is divided in 3 different levels. So at the central level, the district level, as well as at the community level. This training was also underline the training of different offices. In Madagascar, we came up with a training curriculum for especially through the human resources of the Ministry of Health, so that we may have a very good performance. And this training was also followed by the involvement of different civil society organization. And this is some context of the training of the campaign of the year 2024. So it was a hybrid training at each level. So at the central region and at the regional level, so we came up with a number of themes, and those themes are. So we focused on all the activities that was done in the year 2024. And we also we had also the support of the Ministry of Health, as well as the technical team of our technical partners, and the participants were the trainer at the central region, and also at what we call DF. At the district level, we were supposed to have 3 days training on technical aspect of the campaign. So the training at the central level, they train actors at the district level, as well as the district level. And we also train the M&E agent at the district level. At the district level, there was a training on financial management, and this training was a 3 days training. And the sub-committee that funded, as well as train the team, they did it at the district level. And at the community level, a physical training was done. It was a one-day training, and we also added the service provider of OSA. They were the one training the community actors. And finally, for the training at the community level, especially on the distribution as well as campaign logistics, we had a training of one day done by the head of CSB as well as the OSB and the training. So among those that were trained, they were distributors as well as those in charge of the of shops. So let's now discuss on different approach related to the e-learning. Based on our own experience, as well as the vaccination program in 2024, especially in the training of millennium actors, the Ministry of Health recommended the digitalization of the campaign of the year 2024. And the objective of the training was to make sure that trainers are available at all levels, and they will be able to train the others, and they were also supposed to do the monitoring and evaluation. And based on our experience, based on our vaccination experience, we've learned a lot. And this training, it is a very efficient method for training and help us also to understand the needs. And it's a training that is also cheap because we don't need funds for the delegate, for the transport, for the delegate, the hiring of the room and so on. So it is a training that is interactive, and we can adapt ourselves with the current situation. So these slide give us an idea of the different steps that we considered in order to put in place the e-learning. So we came up with a number of modules for the e-learning. And we also integrated assessment for each participant. We came up with the assessment questionnaire as well. We came up with practical exercise like the before and after test. And we also came up with a server that was able to at least support more than 600 users. So, and then we will also do the monitoring as well as the rollout of this training. So in relation to the conception, it is necessary to have at least a system to support this platform. And the system used, it is what we call a module. And we use M&E tool from the participant. And from the module, we also use the score called 5P. And the outcome of the training, you will find it in the dashboard. So we are going to look at the modality of the learning. First of all, we have the content. We created a personal account for each participant, and we also came up with a connection in relation to each and every area. And we also came up with, we organized meetings in order to help each and every participant. And during the training, the central team or the technicians, the central team, they supported the team at the regional and district level. And then we also organized a discussion forum so that the central team could help different participants. Participants can access the first module, and then they will move to the assessment after revising the module. Later on, they'll move to the next module, and at the end, they will be able to do the test or the exams, if I can call it that way. And those results are published by through the dashboard. So finally, in relation to validation, we decided that participants having a score of less than 50% will not be qualified. So those who will have a score beyond 50, then they will be the one moving to the next step of the training. And then later on, they may become a trainer or supervisor of the campaign. So basically, these are the different steps of the establishment of the e-learning of the campaign. So the first step, which focuses on the need, the software, as well as the data from the delegate or participant. And then we needed to come up with a structure, a teaching structure, and then we had also to come up with the content of each and every module. And then later on, we moved to assessment, as well as we tested the structure before roll out the training. And the last step was to the maintenance, as well as the evolution of the approach that we came up with. So what is the different approach that we are implementing, and what is the methodology that we are using for the e-learning? The e-learning approach is much more focused on the learner by favorizing the learning as well as the practical part of the training. So the learner are able to understand and also to learn through others. Of course, it's an online training. We came up with a structure. We structured the content in form of modules. So we had we used the facilitation technique, for instance, the use of a PowerPoint document. And then we came up with a structure related to quiz, as well as the implementation of the online application. So we have what we call NMS platform. And then we also have the adaptation of the standard called ISO-ML 5. These help us to conduct some assessment, and it is also made of a number of quizzes. So, as I said before, during the training, we collected data from people, and we had to train those participants. We had to train them how to use the platform. We were supposed to support them through the central team, especially for discussions, as well as answering during the discussion. So we did it through the data team, as well as the sharing of the data of participant at the end of the training. So basically, these are the advantages of e-learning that Madagascar came up with for the online training. In terms of advantages of the e-learning application about the training of the delegates. So the pedagogic method is quite efficient and also accessible at any time. And this method is less expensive and help us to reduce on movement. And this platform is available 24/7. And these are integrated tools in order to measure the level of the learners. So these are some of the image of the e-learning training. These are the different courses and of each module of the training that participants were able to do during the training. So this is the database of the users. You have the name of each participant. You have their role and the courses that they covered. So this is the content of the course. So you have different training modules, and we also have the forum as well as the section that contain the quiz. Now let's move to the outcome of e-learning for the campaign of 2024. We were able to have 508 delegates who subscribed on our platform, and these participants are spread in 100 districts, and 15 modules are developed as well as shared to the learners. So the participation rate, it is 83%, and the rate of success, it is at 75%. So basically, these are the results in terms of performance by category. So these diagrams show us the performance of the learners in relation to the training they've done. So from these diagram, the performance of the participant can be put in the bracket of 69 to 70%. So the result, I think these are the results that I've mentioned before. It is 75% the performance rate. So these are the outcome of the performance per region. And based on this table, realize that participants at the regional level are much more performant. They're doing better than those who are in the district level. For the participant at regional level, the highest score was 57. So what are the challenges as well as the resolution? First of all, we still have some uncovered area. Madagascar is a big country. Some regions do have telephone network issues, as also we have we have the issue of double efforts. Double activities are done in different areas. The same activities are done twice. So I remember last year we conducted a mass campaign in vaccination and distribution of ITN. That was a challenge for us. We also have the motivation of learners. This is also another challenge because if we decide to do the training online, sometimes some of them are not motivated. So the resolution based on these challenges, we ended up selecting a moderator per district in order to support as well as to support actors at district level if they have any issue. And we came up also with intersectoral coordination. So in relation to solving those issues, First of all, for the maturity of the platform, we have an issue in relation to time. The concept, we don't have enough time, especially like when it comes to deploy the platform, as well as the design of the platform. It takes time. So we ended up removing some options and so on during the training. So in relation to the challenge based on the e-learning, as I said before, we have issues in relation to internet connection. Sometimes the connection is unstable, and some places, some areas, connection is an issue. We also have power cuts. That is an issue in Madagascar. So based on all these issues, we have a problem to really run this platform 24/7. 24 hours for 24 hours. So we also have issue for the login for each participant. This creates some kind of delay for the training, especially for the first day of the training. So based on this issue, we had to work on the login and the password of each and every participant, and help those, and also look at the issue of those who are logging in late, and those who are having issues for logging in. So what are the recommendations based on all these challenges? First of all, we need to have enough time for the rollout of the e-learning platform. We need to inform the user in advance and explain them how to use the platform, to help them familiarize with the platform before the training. We need to also try to explore other methods of learning, like especially for districts that are covered with the mobile network. So we need to find out we need to know how to deal with those different districts. So to finalize, I would like to share with you some advantages of e-learning for the campaign of the year 2024 in relation to efficiency costs. The cost is less, especially it has reduced the issue of transportation and so on. So the learning also part is quite flexible, and we came up with a number of documents based on that. In terms of access, we had some issues. The training is uniform, and it is the same for each and every participant. So we came up with a discussion forum. So we were able also to do some monitoring and assessment of each participant using the same platform. So I would like to thank you, and I'd like to thank the whole team who took part in making this presentation. Thank you so much.
Thank you very much.
Thank you so much for the presentation. We are now open for questions, comments. Okay. You don't overwhelm me with plenty of questions. Okay, so we'll see. I will take Giovanni first. I saw a hand. I will take one person from between you and Robert. You have to decide which one. We'll take somebody from the middle, and then we'll take one person from here. Giovanni, let's start with you.
Okay. The question is to the Ghana team. Thank you very much for the experience in Ghana, especially on optimization. I just have learned about optimization under resource efficiency in terms of human resource, time, and money. Maybe you need to link optimization also in terms of coverage so that you can have the impact. Having said that, beyond the operations, do you have the details of the budget allocation? Considering that we are looking at the distribution of nets, using one net to $1 for the in-country operation, what is the experience of the monies you are spending against the dollar? Then two, when you get into down of the budget allocations, do you have the estimated allocations by what's the proportion of logistics out of the total budget, SBCC, M&E, and operations to guide the other countries' programming, because they vary from country to country, so I can benchmark some of your documentation and optimization. Thank you very much, and I appreciate your findings. Over.
Thank you. My question is in French, c'est pour le Madagascar. C'est une question par rapport aux résultats ou la performance. Donc, vous avez dit que le taux de participation est de 83% et le taux de réussite 75%. Donc, comme c'est pas un cours où on a un certificat ou un diplôme, c'est pour aller faire la mise en œuvre. Maintenant, les gens qui n'ont pas réussi, j'ai pas compris, qu'est-ce qui se passe? Vous les remplacez? Il y a un coup de rattrapage? Ça se passe comment pour les gens qui n'ont pas réussi le cours? Merci.
Eli from Blue Square. I would have some questions for the Ghana presenter also about more the micro-planification part of combining BedNet distribution and SMC, and the challenge when you have different target group and how you address it. Do you split the micro-planification? Do you have different data sources that you use there? Et j'aurais quelques questions pour Madagascar aussi au niveau.
I have a question going to Madagascar. Similar to that of Giovanni, and maybe in future, while doing this, you are going to bring together participants for e-learning, and maybe you can have a window through which they can do their exams, or maybe follow through with this training in order to have a certificate or maybe a diploma. And maybe, I don't know if you envisage this and the issue of connectivity. I don't know if this remains, and could you use some temporary school strategy, for example, in order to deal with the issue of coverage? I don't know if you have this solution for people who have been trained, maybe as some sort of a summer school, or maybe something like that. Maybe you can do this in order to give some certificate at the end of the training, and maybe this is an idea you can explore as part of your e-learning. Thank you.
All right, thank you. My question is to the Ghana team. I will start by appreciating the Ghana team for, the integrated campaigns. Of a truth, as you said, to integrate SMC and ITN is a very big challenge. And speaking from Nigeria, I see that the lessons we can share and learn from each other. And, to start with, from your slide, you mentioned integrating in the first cycle of SMC. But I want to ask, aside first cycle, is there any other cycle within the 5 cycles you have, which is best to integrate SMC? And what informed your choice on the first cycle? And this is because you may plan to start or plan to integrate the ITN campaigns with the SMC first cycle, and you could be faced with a critical challenge like delay in the arrival of nets. So we all know that SMC is certain. Rains don't wait for you. You have to proceed with the SMC implementation. So what is the next best cycle to, integrate and achieve the maximum value for both cost efficient optimization? And my second question is around the SBC integration you mentioned. So I wanted to know how that was done, and to what degree did you integrate the SBC component? Thank you so much.
More from this side. I saw hands up. Yes.
Okay, thank you so much. This is to the Ghana team, to the Ghana presenter. Thank you so much for the presentation. Pardon me if I missed this out. I just wanted to know, it's good for to integrate, it's really good. As you said, it's less cost implication. What I wanted to know is about the bring your own device. Did you face any challenges, or did the team face any challenge in bringing their own devices? Probably I missed that one, please. I just want to know whether there are any challenges with the teams when they use their own devices to do the campaign. Thank you very much.
We'll take my friend from Mozambique.
Yeah, thank you. My name is Alpha from Mozambique. So my question is about the approach, bring your own device to the campaign. The question is, after the campaign, how the team make sure that the users after the campaign will not still enter the data and sending to the platform?
Okay, you can answer the first round, and then we'll take another round of questions. Sandra, we'll start with you after.
Hello. Yes, thank you for the questions. I'm looking at my session chair why she asked him to ask the first question, because that's a bit difficult. It almost felt academic on proportions and other things. What I can say is that there are cost savings. I'll give you one example. So for just the integration, SMC integration, we are looking at around 600,000 USD savings. That's just one element. I don't have the facts for the code cards and the movement of tablets, but this is just to give you an idea that a lot of money is being saved. When I am trying so hard because I don't have the facts about the proportion of logistics, I'm sorry, I would have to go back and then I don't have the facts. But they are good thoughts to think about, so thank you on that. Should I go on? Right. So there was also one on the target groups for integration. Yes, the two activities or interventions have target groups. So for volunteer during SMC, when we're doing the individual ones, SMC, we are expecting you to spend between 20 to 30 minutes per household. ITNs, you're expecting to do something less during integration, and per volunteer during SMC, you were supposed to dose like 50 children per day. For PMD, you are expected to register, let's say, 100 or more per day. When we integrated, we factored all of that in, some trade-offs, and came to a target that is feasible for all volunteers. So it came to 5 days implementation. Volunteers were expected to dose 30 children per day and register 50 households per day. So that all goes into your M&E. You plan, you do your targets, you look at the days. It's well planned and it works out. But of course, supervision is what will get the volunteers to meet their targets. And there was another about the cycle. So you also alluded to the fact that SMC timelines are fixed. We don't change that. We rather bring PMD closer to ITNs. Because the good thing is that ITNs were already procured, we had them in country even before we started the campaign. So there was no challenge of we have timelines that we are not able to meet because nets are not in country. It also became feasible because we had a plan, and it just so happened that SMC happening in the northern parts of the countries were scheduled for early parts of the PMD campaign. So it just worked out that the first cycle, which is around June, was also around the same time that we had planned to do PMD. just a few regions that we had to move, one region that we had to move into the timeline, but they all worked out. And I think there was one on SBC integration. So integration on all levels. So with the development of your jingles, with your stakeholder engagements, the people you are bringing into the room, you are not talking only PMD, you are also engaging them on SMC, their roles, spelling it all out to them. Stakeholder engagements, they are not just an event, there are the events and then the follow-on discussions, and the expectations that you have of them playing their specific role. What's the education team doing? What's the police service? What's every stakeholder should be brought on board. And clearly, once it's the household, you also need know that their support goes for every activity that has to do with the household. And then the last one has to do with BYOD, bring your own device. So it had challenges, but one thing about my program manager is that she likes challenges, and you will brace yourself and you'll get it done. And we have done it in tougher conditions, and it always energizes us to take on more. And we knew it was going to be challenging, but we also braced ourselves. One thing, some of the things we're thinking about, so I'll give you one example. We do validation. The data is sat on people's phones. What's data integrity? Someone can run with your data. How do you deal with all of that? So we had to put in measures. And daily supervisors were supposed to, so some aspects we didn't even leave for the volunteers, like the synchronization of data was left for the supervisor. So one thing the supervisor does is that you will assess the work of the volunteer and record its offline data, because one aspect of validation is comparison, comparing offline data to synchronized data. That's very key for our synchronization. So that should be done by the supervisor. And when it is done, it's done on a daily basis. You don't have somebody data running or something. It was also tied to payments. So you don't get your payments until you have been cleared with all your data. The good side, I know you didn't ask about the good side, but one good side is that people are more conversant with the use of their personal phones. So they found it rather easy navigating on their own personal phones. At the first thought of it, people will come with objection, but you do it one, and you do it in a difficult region, and all the other regions don't have an excuse, especially when they are less difficult to work in. So we did it in northern part of the country, which is difficult on all counts. So you go to another region with good internet connectivity, with relatively educated volunteers. What's your excuse? We are bringing in lessons. So these are some of the things that we leveraged on, but it was difficult, but the lessons are there to be shared. Yeah.
Merci pour la question. Je vais essayer donc de répondre, mais il y a aussi d'autres collègues.
There are some other colleagues who could also respond to this question. So first of all, when it comes to the results of the training, e-learning training in Madagascar, the 75% success rate. And how are we going to do it in order for the 25 participants who failed in this training? What are we going to do for them? First of all, the e-learning training had an objective, which was to have good trainers in each and every district, because this was a cascade training. So there are no certificates to give to the participants, but the solution that we took with regards to participants who did not succeed in this training, we did some catch-up training,
accessible
and we ensured
that que les participants peuvent donc refaire la formation et aussi la quiz. Donc, et après cela, nous avons donc évalué les participants afin qu'ils puissent conduire donc des formations au niveau de chaque district. Ensuite, pour la raison des connexions, pour les participants qui ont des problèmes de connexion durant la formation, il y avait donc une organisation au niveau de chaque district ayant des problèmes de connexion. Donc, les participants doivent donc partir rejoindre les participants au niveau des districts ayant une bonne connexion. Donc, il fait la formation au niveau de ces districts-là. Voilà ce que j'ai reçu, mais s'il y a d'autres questions, donc, je peux répondre donc, durant cette formation, durant cet atelier-là. Merci.
Another round of questions, after which we have one more presentation before our break. Sander, you have your hand up.
Okay, thank you, Dr. Wapo. Actually, my question goes, I don't know if I'll call it a question, a comment, or a request, but let's see. So, goes to Ghana. Let me start by saying thank you for the great presentation, and especially I like the way how we represented the supervisor and the volunteer. You know, you can read it both ways. The volunteer running away from the supervisor, or the supervisor chasing the volunteer. So my question is, would you mind sharing briefly how we have your structure for the monitoring and supervision, and at different levels? Over. Thank you.
Any other question in the middle? Okay, we'll take Alade. Anyone on this side? I'm standing because I'm vertically challenged and I want to be fair to all concerned. So, if you have a question, please raise your hand. Okay, this way. All right, after Alade, then we take you and you. Okay, just him.
Okay, thank you. My question is to my Ghanaian friend. You know, we interacted a bit during the launch, and there were one thing we discussed, that was the door-to-door. And I saw in your presentation that the first time you implemented it, like I said, it was a challenge, but then you moved to PMD. So my question, what I want you to help me with is, how do you manage the PMD in urban area, especially where we do, our people believe that when you go to them to register them, they expect you to go to them with their nets. Now, my second question has to do with the bring your own device. It's quite an interesting part of your campaign. But let's understand the users, people who they come with their own phones, they can do anything with their own phones, and you are relying on them to do your work. Do you have some sort of control over the phone, or you leave it with them because the man has his own internet on his phone and he can work on his phone, browse, do whatsoever. At the same time, you are waiting for him to collect your data and send it to you. And you also say you have supervisors that do the syncing of the data. I find it a bit difficult. How do I copy that, especially if a supervisor is to supervise probably, let's say, 10 persons, and he has to visit those 10 persons before moving the data to the server? I mean, what were the challenges? What were the difficulties in that? Thank you.
Ok. Merci bien pour l'opportunité. Ma question s'adresse au Ghana. Please, can you use? Okay. Ghana. Okay. Donc ma question s'adresse au Ghana. En tout cas, je vous remercie et vous félicite pour cette intégration. Je reviens sur la question de la microplanification. Et dans les domaines qui ont été intégrés, la microplanification n'est pas ressortie comme un des aspects que vous avez intégrés. Est-ce qu'il y avait des difficultés qui ont été identifiées en amont qui vous ont amené à ne pas intégrer la microplanification de la distribution de masse et la CPS? Et puis une dernière question, est-ce que vous avez fait une évaluation d'impact et de couverture entre les 3 zones? C'est bon? Is it okay?
Is it okay? You want to answer right away? Yeah, sure.
I don't understand.
Perfect. Yeah.
Hello?
Yeah.
Yes. Clarity. Impact on which, you said 3 areas. What area?
Ok. La question est de comprendre, est-ce que vous avez fait une évaluation de la couverture des 3 approches, SMC seul, l'intégration SMC campagne et puis la campagne seule, par rapport à la moustiquaire, bien entendu. Est-ce que vous avez évalué?
Right. Thank you. For more questions, visit Ghana. But just to start on monitoring and supervision structure. So it's at all levels. The primary supervisors are there. Okay, so just a background. We have the community, we have the sub-districts, we have the districts, we have the region, and we have the national in that hierarchy. The sub-districts and the district supervisors are close to the supervisors, so they use one checklist, and that checklist primarily is assessing the volunteers' performance, the support equipment and logistics available to him or her, and stuff like that, whether or not the households are being educated, the right questions are asked. So there are specific checklists for that level, sub-district supervisor and district level. The other tier is the regional level, and that's what I was saying, that previously we're using the very same checklist, so it was more like a duplication of efforts. Now what the region and the national team does is that they use data from the districts and sub-district teams that have supervised day one and sometimes even before, to identify the problem areas. They zoom into the problem areas and offer more like a hands-on support to them. I don't know if I've answered that question. And then the next question is PMD in urban areas. PMD in urban areas is challenging. And the discussion over lunch, I think, will continue because we still don't have a solution. Personally, I feel that we need to reduce the quantity of nets that goes in, but it has to be scientific. We have tried it in previous campaigns. We were doing registration targeted. Sorry, not targeted. Targeting all populations. In this campaign, like I mentioned, we staggered the population targets between 40 and 60. One very urban region called Ashanti region in Ghana, what we did is that we actually put in this thinking when we were going into registration. So we had done the micro planning, but going into registration, we actually targeted 30% for some very urbanized districts, 70 for some peri-urban, and 100 for some rural. Even that, the 30% coverages for the very urban, we found some districts struggling, and this is all to buttress our points that there really is no point sending so much nets for places where they don't need it. And the challenge is that when you push them, they will give you the results, and you see that in the coverages. So day 1 to day, if you do a campaign for 5 days, day 1 to day 3 is critical. You see the struggle. And when you find them struggling, and then the last day there is a massive jump, you should know that they've done something wonderful. and that is to manipulate or do something just to meet the coverages. And we are moving away from being coverage conscious to actual impact. One of the things that we did also in this campaign is that even in urban areas, we're also gathering data on refusals. And we get refusals at registration. People will refuse the nets. Some of the things we are hearing is that probably I have enough nets already, and it's usually coming up in urban areas. People are saying that I have alternative protective measures. So these are all some of the reasons why people don't need a net, and we are documenting it in urban areas. And this should go in our strategy. I look to a future where probably we are either just going to do what I saw here, the community ITN for those who really need it and the subpopulation that are really at risk in these urban areas. But of course, you supplement it with an alternative vector control like larvicidin or something, just so that they are also well protected. But ITN in urban areas, there generally should be a rethink on that. And microplanning, true. So we not necessarily integration, but I would say we use data from one for the other. PMD microplanning is quite intense. The team, we go to the district, we sit down with them, we use a template. Thanks to AMP, their template has actually evolved over time. Now we have a very solid template. We do that, we use a template, we sit down, there's a lot of money spent. You have to go to all the region, you converge all of these people, 2 days per, that's a lot of money. SMC teams did not need to do that. They just picked the data from PMD. They did a desk review, consulted a few things, and they had their microplan ready, and they have used it, and there were no issues with that. So that's one of the things that we have done. Challenges with synchronization. I don't know if I've missed the question. The challenge with supervisors synchronizing the data. We feel it's necessary. It's difficult, but we feel it's that's the only time supervisors are actually interfacing with the volunteers. So all the support they need before setting them up, and the feedback they get from a day's work is also very, very critical. And they get that when they are engaging them after the day's work, prepping them for where they've gone wrong, what they can't do for the next day. So we still feel like it's challenging, but it's necessary. And if it's well thought through, they have an area where they converge, or the supervisor has access. Their mobility is easy, so they're able to move. They are either using a motorbike or something, so it works.
Thank you. So before we take our tea break, we'll call on Joyce that will drive us through the mass distribution campaign of long-lasting insecticide-treated nets in DRC between 2018 to 2021. Joyce.
Alors, bonjour tout le monde. Je vais partager avec vous l'expérience de l'utilisation des formulaires digitalisés des dénombrements pour essayer de contrôler les cibles à atteindre en termes de couverture. Nous avions des défis à relever du point de vue des dénominateurs, et nous avons également eu des défis, comme vous le savez, des défis de nature sécuritaire. Et donc, l'outil nous a aidé quand même à trouver des solutions par rapport à un certain nombre de défis qu'on avait sur le terrain. Et donc ma présentation va avoir deux parties. Dans un premier temps, je vais parler des aménagements sur les formulaires de dénombrement dans un contexte stable, et des aménagements que nous avons faits dans un contexte d'insécurité. Et c'est un travail que nous avons fait avec beaucoup de soutien de la part de l'AMF, parce que l'équipe de Julian, que vous voyez, pour nous, c'est un gars qui est de chez nous, quoi. Parce qu'en fait, chaque semaine qu'il est avec nous en discussion, et avec l'UITRN du Fonds mondial, c'est des gens avec qui on réfléchit de manière continue, c'est à un rythme hebdomadaire qu'on a des réunions. Et je vous rappelle toujours, quand on a commencé aussi à construire les approches basées sur les résultats avec Marcy, Marcy aussi nous a accompagnés pendant un an, plus d'un an, avec des réunions hebdomadaires, et finalement, C'est des gars de chez nous, je crois qu'on va débaptiser quelques villages pour leur donner les noms là-bas. Alors, donc nous avons regardé les campagnes sur 3 années, entre le NMF2 et NMF3. Nous avons publié d'ailleurs ces données-là. Ce que nous avons observé, c'est que avant la digitalisation et après la digitalisation, nous avons vu des différences en termes de taille de ménage, en termes de nombre de ménages dénombrés comparé aux ménages planifiés. Donc, quand nous regardons ce qui s'est passé en termes de population, nous avons vu qu'en moyenne, il y avait 7% d'accroissement des populations, mais que si on regarde les provinces qui avaient fait leur campagne avant la digitalisation, on avait un accroissement de 9% des populations, alors qu'on n'avait eu que 3% d'accroissement après la mise en place des outils digitalisés. Et ça, c'est au niveau population. Et au niveau ménage, c'est à peu près la même chose. Et donc, si on regarde un accroissement plutôt négatif, mais quand on regarde avant la digitalisation, il y a un équilibre. Donc, en fait, les ménages ne sont pas si nombreux que ça, mais la population semble croître de manière importante avant la digitalisation. Donc, on a l'impression que les ménages déclarent trop d'habitants. Vous voyez ? Parce que lorsqu'on les compte, ils ne sont pas si nombreux, ils sont même inférieurs aux projections. Donc on s'est dit, ça y est, on tient la solution avec la digitalisation. Donc on était enthousiastes, c'était très bien, ça y est, on a trouvé la solution. Mais attention, en regardant de près, on se rend compte qu'en fait, lorsque on fait cette comparaison à l'intérieur des mêmes strates, en réalité, l'accroissement, que ce soit avant ou après digitalisation, en regardant la taille moyenne des ménages, en réalité, il y a un accroissement de 11% parmi les provinces avant digitalisation, et c'est le même niveau d'accroissement après digitalisation. Donc, en réalité, c'était une illusion. Donc, il fallait trouver autre chose. Autre chose. Alors, qu'est-ce qu'il fallait faire? Donc, on s'est dit, OK, c'est pas un problème congolais seulement. Hein. La tendance à vouloir dire qu'on est nombreux pour avoir plus de moustiquaires, c'est quelque chose que nous avons vu également dans une campagne digitalisée au Bénin. Au Bénin, ils avaient un accroissement de 9% en termes de ménages par rapport à la planification, et un accroissement plus important en termes de population, de 13,55%. Donc en fait, c'est quelque chose que l'on trouve partout en réalité en Afrique. Et bon, le Bénin avait l'avantage d'avoir un buffer, un gigantesque buffer de 30% de moustiquaires en réserve. Ça, c'est le paradis. Nous avons travaillé avec un buffer de 5% pendant les 9-10 premières années des campagnes, depuis 2009. Et puis après, on est venu avec Julian et Louis Terren qui nous accompagnaient, commencer à dire non, mais 5%, finalement, vous avez toujours un peu de reliquat, on enlève même les 5%. Donc en réalité, la RDC n'a à 0% de buffer. Et donc nous, on ne peut pas s'autoriser à avoir des accroissements par rapport à la planification si importants, parce qu'on n'a pas de moyens de combler pendant la distribution. Et donc, ce qu'il fallait faire, c'était de trouver les moyens de contrôler les opérations de dénombrement pour s'écarter le moins possible des projets de planification. Et donc, parce que nous savons que lorsque vous avez des surestimations comme ça avec des populations déclarées élevées, ça vous entraîne des inefficiences, parce que vous allez acheter plus de moustiquaires que nécessaire en réalité, et que donc, puisque nous n'avons plus de micro-planification, de dénombrement avant distribution, nous faisons les tout à la fois. Nous passons, nous dénombrons et nous laissons les moustiquaires. Avant, quand il y avait deux phases, on pouvait avoir un temps pour régler un peu les choses, Mais là, on n'a plus ces leviers, vous voyez. Et donc, on fait une micro-planification sur les données des campagnes antérieures. Et donc, finalement, la distribution va se faire avec beaucoup de soucis parce qu'au moment où si on ne contrôle pas bien cet élément de dénombrement, on va avoir des problèmes de rupture de stock dans certaines régions et des redéploiements à faire avec des coûts logistiques. Et on va donc avoir des données biaisées que l'on va utiliser pour les campagnes futures et on est dans un cercle vicieux. Et donc c'est là qu'on a dit qu'il faut faire quelque chose, il faut réfléchir. Et on a dit on va travailler sur les formulaires. Donc qu'est-ce qu'on a fait? Ce qu'on avait avant, c'est que lorsque les relais communautaires, l'agent de santé communautaire arrivait dans un ménage, il demandait combien de personnes habitent dans le ménage. Et donc, on avait également des segmentations des enfants de moins de 5 ans pour nos collègues du PEV qui voulaient utiliser ces données pour planifier les campagnes de vaccination. Donc, c'est tout ce qu'on faisait, c'est compter le nombre de personnes déclarées par le chef des ménages et puis demander s'il y a des enfants qui ont la tranche utile pour le PEV. Mais on a changé ça. On a changé, donc on a dit, au lieu de demander combien de personnes habitent dans les ménages, on demande des tranches. On demande déjà combien il y a des enfants de 0 à 5 ans. Et puis on demande combien il y a des enfants d'âge scolaire. Et combien il y a des personnes adultes de plus de 18 ans. Et donc lorsque le relais communautaire pose les 3 questions, ici c'était 0 enfants de 0 à 5 ans et puis une personne de 6 à 17 ans et 2 adultes, donc les chefs de famille. Immédiatement, le nombre total apparaît. Donc, on n'a plus besoin de vous demander combien vous êtes dans la maison. Donc, ça évite que les personnes trichent comme ça facilement. En plus, on a rajouté des contrôles. Pour chaque tranche, on a mis des limites. Lorsque vous dépassez 3 personnes de moins de 5 ans, vous devez dire les liens de parenté de chacune d'elles. Et donc, si vous restez dans un chiffre raisonnable, on ne vous pose pas de sous-questions. Et donc, ça permet d'engager les relais communautaires à aller explorer les raisons de grands nombres dans des ménages. Et donc, la conséquence, c'est que les relais communautaires, puisqu'ils connaissent les ménages, ils n'acceptent plus les réponses fantaisistes parce que ça lui prend plus de temps. Parce que si vous donnez un grand chiffre, ça ouvre des sous-questions et ça prend du temps, du relais. Le relais, après le premier jour, il devient strict, il vous connaît, vous n'avez pas plus de 2 enfants de moins de 5 ans, vous en avez un seul. Et donc, du coup, c'est le relais qui devient le contrôleur des tailles de ménage. Et ça vous donne automatiquement le nombre total de personnes dans les ménages. On met un deuxième contrôle. Après, on demande combien avez-vous de personnes de sexe féminin? Combien avez-vous de personnes de sexe masculin? Ça doit correspondre au même total que le total que vous aviez donné sur les tranches d'âge. Et donc, ces 2 contrôles, nous avons mis en place pour essayer de contrôler la taille des ménages. Qu'est-ce que ça nous a donné? Nous avons commencé cela à la Mongala. Et donc, vous avez vu que entre la campagne précédente où on n'avait pas mis ces contrôles et la campagne avec le contrôle, on a réduit les ménages de grande taille. La deuxième province qui a fait la distribution a eu également ces mêmes effets de réduction de grande taille, des ménages de 7, 8, 9 et plus. Il y a eu des réductions. La troisième province, c'était la même tendance de réduction de grande taille. Donc, au total, en moyenne, on a vu quand même que les campagnes avaient réduit les ménages de grande taille en faveur des ménages de taille moyenne, de petite taille, avec un resserrement autour de la moyenne. Et donc, nous pensons que ça nous permet de un peu contenir la tendance à l'exagération de la taille des ménages et avoir ainsi moins de dispersion vers les grandes tailles, des meilleurs dénominateurs, et donc nous permettre de planifier les prochaines campagnes de manière un peu plus sereine. Maintenant, en situation d'insécurité comme l'Ituri. L'Ituri, c'est une province au nord-est de la RDC, où en 2021, lorsqu'on devait faire la distribution, nous avions 11 zones de santé qui avaient de l'insécurité parmi les 36 zones de santé. Et ça, c'est pendant la micro-planification. Et après, au moment de la distribution, il y a eu des zones supplémentaires qui sont rentrées en situation d'insécurité. Mais les problèmes, c'était de savoir comment allons-nous faire pour atteindre les ménages, les personnes déplacées, et avoir également des données et des statistiques différenciées qui nous permettent de savoir quantifier l'effort et la couverture de ces personnes. Et donc, nous avons pensé qu'il fallait travailler pour faire une campagne qui prenne en compte les personnes déplacées qui sont fragilisées par leur situation et qui sont donc plus à risque de paludisme. Donc, il fallait savoir comment les identifier et comment les servir en fonction de leurs besoins en termes de taille de ménage. Et donc, pour y arriver, nous avons commencé par catégoriser les populations. Nous avons l'habitude de faire deux types de catégorisation. Les ménages que nous appelons traditionnels, c'est des ménages qui habitent autour de l'autorité d'un chef de ménage et qui partagent un repas ensemble, et qui sont différents de ce que nous appelons les ménages spécifiques, qui sont des personnes qui vivent dans des camps, dans des orphelinats, qui sont plutôt en maison institutionnelle. Mais maintenant, en situation d'insécurité, les ménages traditionnels, nous avons pu identifier 3 modalités. Des ménages qui sont autochtones, des ménages qui hébergent des personnes déplacées en leur sein, et des ménages qui se sont constitués de manière séparée, mais qui sont des déplacés. Et dans les camps, on a également, dans les ménages spécifiques, on a des ménages qui ont été installés dans des camps ou dans des écoles de manière temporaire, et qui sont donc des ménages qu'on appelle spécifiques, puisqu'ils ont des places à coucher qui leur sont attribuées, et donc qui vont nécessiter des moustiquaires. Et donc maintenant qu'on a fini une fois qu'on a fini de catégoriser les ménages, on a construit notre formulaire de manière à spécifier la qualité des ménages. On a mis des questions qui permettent d'ouvrir, de catégoriser les ménages plutôt, de manière à ce qu'on puisse avoir des données séparées. Et puis, on a commencé notre distribution, on a formé des équipes en fonction de ces nouveaux formulaires. Et nous avons donc pu avoir, dans la province de l'Ituri, qui avait planifié 1 368 272 ménages, on a pu atteindre 85,6% des ménages. Et là-dedans, on avait 2,9% des ménages qui étaient des ménages traditionnels qui avaient accueilli des déplacés en leur sein. Alors, ces ménages-là, ils avaient les moustiquaires en fonction de la taille des ménages augmentée par des personnes qu'ils ont accueillies. Et puis, il y a à peu près pas loin de 5% des ménages qui étaient vraiment autonomes, déplacés, mais installés de manière à part. Et ça fait donc, en termes de population, on a réussi à dépasser les 91% de population planifiée. Donc, vous voyez que, puisque les ménages ont absorbé un peu plus de population, en termes de population, la performance était quand même très intéressante pour une situation d'insécurité comme l'Ituri. Et pour ce qui est des ménages traditionnels, 11% des ménages plutôt spécifiques, c'était des camps de déplacés. Mais en termes de nombre de moustiquaires distribués, ça représentait pratiquement un tiers des moustiquaires servis aux ménages spécifiques qui étaient attribués aux déplacés qui étaient installés dans des camps. Donc c'était pour nous quelque chose de très intéressant, parce que c'est vrai que nous avons eu quelques soucis, parce que cet effort d'intégration, on l'a fait vraiment in extremis vers l'approche de la campagne. Il fallait adapter les outils, et donc c'était vraiment un temps très limité. Il y a également des problèmes qu'il fallait résoudre en termes de redéploiement des moustiquaires, parce que les moustiquaires avaient déjà été rendus dans les zones de santé, donc il a fallu les ramener. Ce qui a été intéressant surtout, c'est le fait d'avoir travaillé avec les agents humanitaires, notamment Caritas Congo, qui travaillait avec HCR, qui avait déjà des effectifs de déplacés. Ça nous a permis, par exemple, de ramener 50% des moustiquaires de la zone de santé de Nyankoundé vers Bunia et 20% de la zone de santé de Boga vers Bunia avant de commencer la campagne. Et donc, ça nous a permis d'avoir un stock, sachant que la plupart des déplacés venaient vers les chefs-lieux à Bunia. On a également utilisé une autre approche de commencer dans les zones de santé par distribuer, sauf dans une aire de santé, autour du bureau central, pour avoir le moyen d'abord de servir les zones qui seront en rupture, qui ont reçu des déplacés, et comme autour du bureau central c'est logistiquement plus facile, appeler ensuite les moustiquaires du dépôt intermédiaire de Bunia pour combler. Et donc ça nous a permis de solutionner des problèmes logistiques et de servir au maximum les populations déplacées. Et donc les leçons apprises, c'est qu'une catégorisation préalable des ménages et une cartographie des ménages avant la campagne dans un contexte d'insécurité, c'est quelque chose de très important. Et les populations vulnérables et déplacées, qui sont souvent marginalisées, peuvent être servies, même en situation d'insécurité, surtout lorsqu'on les a bien identifiés, bien cartographiés, et qu'on les utilise également comme acteurs de distribution. Et puis voilà, donc et ce qui a été intéressant aussi, c'est que lorsque les ménages ont appris qu'on allait distribuer, dans certaines zones qui avaient un peu retrouvé le calme, même lorsque les ménages hésitaient pour revenir, certains sont revenus pour ne pas rater leur moustiquaire. Donc c'était aussi une opportunité pour le retour de certains ménages dans leur foyer. Voilà. Merci, j'avais eu très peur que je fasse 40 minutes avec ma présentation. J'ai dit et je vous remercie.
Thank you so much. You see, the clap in the room tells me that it is well understood. So no need for a question, right? We'll take two, one from here, one from here. Marcy.
Thank you, Joris, and particularly for staying to time. So there's a backstory that I've been telling Joris that the Francophones take too long. So that's why we're joking about him being exactly on the 20 minutes. So first, thanks a lot for the presentation, super useful. I have a question a little bit side. One of the things we need to talk about is data and how we're both using and reusing data. You referred to collecting data for the EPI program and the age groups for EPI. And with a digital platform, we have so many advantages on how we can contribute to better health across programs, not just for malaria. So I wanted to understand, Joris, how those data are being used, how you as the malaria program are combining and partnering with
Recording
EPI
in progress.
To ensure that we get the health outcomes for children under 5 that we're looking for in DRC. Thank you.
Any other question? Okay, let's take you from South Sudan.
Yeah, thanks so much, Congo, for the nice presentation. South Sudan did a distribution in 2023, and our model was almost similar. I just wanted to inquire from you, in the Kobo, I've seen you have used Kobo Collect for the distribution. For us, we use DHIS2. So in the DHIS2, there's a functionality that you can activate to really tell you the number of people in the household. If you put the number of household, you put in a formulas that says 1 net per 1.8 person. So there's actually a formula that you put from there. How did you do it in the Kobo Collect? Because if it is one person, you give a 1 net. If there are 2 people, you give 1 net. If there are 3, you give 2. That was a formula we used. But to your presentation, I haven't seen that. 2, I haven't seen the disaggregation of, in regards to the pregnant mothers who are actually the vulnerable people that were to be protected using the ITN. And the definition of a household, what was the average number of people expected to be in a household? For South Sudan, the average household is 6.6. So I don't know in Congo. Kindly let me know, because you can't start the distribution, the mass campaign distribution, without a micro plan that will tell you how many people are in a household, how many net that should go to them, and what is the average size of a household. So I just want some more clarification from that. Otherwise, thank you.
Okay, that's it.
Merci beaucoup. Merci. Vous voulez savoir comment nous partagions les données avec le PEV pour son utilisation. En fait, il y a eu une démarche d'harmonisation. Donc on a discuté avec l'équipe du PEV sur les tranches utiles pour le PEV. Donc il y avait les enfants avec les différentes tranches d'âge en fonction des antigènes et les femmes enceintes. On avait paramétré ces éléments-là dans le formulaire. Et donc on recueillait ça et on pouvait ressortir pour chaque entité, aire de santé, zone de santé, les populations, les fractions utiles pour le PEV. Mais je dois avouer que les données n'avaient pas été consommées par nos collègues du PEV quand nous les avions produits. Et donc, en fait, finalement, on s'est dit, tiens, donc on est en train de mettre du temps à produire des données qui n'étaient pas utilisées. On a rétro-pédalé et on a privilégié l'approche que nous avons présentée ici pour contrôler notre dénominateur. Et donc, on est revenu à moins de 5 ans, 6, 17 et puis plus de 18 ans pour mettre des contrôles et avoir des tailles des ménages contrôlées. Donc, je trouve que c'est dommage, mais nous avons pensé que lorsque quelque chose n'est pas utilisé, il ne faut pas le collecter. Mais maintenant qu'on est en train d'aller vers une intégration des campagnes, pour l'instant on est en train de faire une intégration, je pense que cette question de retour aux tranches utiles pour les PEV est sur la table, et puisque maintenant c'est piloté par l'ANI-CNS, qui est un peu l'autorité de gestion de données, ça va donner un peu plus de pouvoir et un peu plus d'injonction aux autres programmes pour consommer les données qui sont fournies par les efforts des autres programmes. Alors les amis, les collègues du Soudan du Sud disent qu'ils utilisent les DHS2, nous on utilise l'ODK, et dans cet ODK, vous avez vu que, je ne sais pas si je vais aller passer peut-être un peu rapidement, mais lorsque vous finissez de prendre le nombre de personnes dans les ménages, il y a automatiquement le nombre total des habitants du ménage qui sort et la question qui suit. En fait, lorsque vous avancez avec votre questionnaire, ça vous donne le nombre de moustiquaires à remettre. Parce que derrière, c'est déjà paramétré pour des ménages de 1 à 2 personnes. Une moustiquaire, donner une moustiquaire. Donc, le téléphone va dire au RECO, vous avez trouvé 3 personnes dans ces ménages, vous devez leur donner 2 moustiquaires. Donc, c'est déjà paramétré dans le questionnaire, en fonction des tailles de ménage. Voilà. Maintenant, la planification, la micro-planification, c'est fait sur base des données des dénombrements antérieurs et la taille des ménages utilisés pour faire la planification, c'est des données des enquêtes EDS les plus récentes. Et c'est la taille moyenne des ménages en RDC, c'est 5,1
une personne par ménage, mais ça varie entre 4,2 dans les provinces, dans la cuvette centrale, hein, la partie forêt, à 5,7 ou 5,8 dans les provinces de l'Est qui ont un peu plus d'habitants par ménage. Donc ça, c'est des données qui sont connues et c'est même connu par province et ces données-là sont utilisées au moment de la microplanification. Je crois que j'ai répondu aux questions qui m'ont été posées.
Merci. Join me as we give a round of applause to our presenters. Thank you so, so much. So you have 10 minutes break, 10 minutes only. You will be back here by 3:45. Yes. Thank you. See you soon. And this presentation is intended to keep your gray matters functional. You would think after this one. And this presentation will be done by no one else but our own Marseille. She will outline and provide clear guidance. She's going to be providing us clear guidance and key considerations as we move towards our preparation for the ITN 2025-2026. So help me to give a round of applause to Masi.
So it's been a long couple of days, and I definitely should not have to follow Joris after he presents. No pressure on that one. Let's see if I can make this thing work. Could be stuck on the first slide. So we'll start again, as every year, to just say thank you to everybody. So give yourselves a round of applause. It's been a hard year. I think today my name might be Peterson. So I might be messing up everybody's happy supply chain with this presentation. So just wanted to frame that maybe appropriately. I want to thank Chai for this slide. And I think it's a really critical slide. And I think it helps to contextualize the messages that we've been trying to pass over the last 2 days. So this on the left looks at the donors to malaria in 2022. And the stars represent our biggest donors. And on the right, this is GC7. So this is our grant cycle 7. So I'm going to stop. Put up your hand if you see that we're going to have a better replenishment in 2025. Okay, so everybody got the message. So this is where we start, and I think, these are the things that are going to be critical for us. And it's not thinking about GC8, it's thinking about what we have to do now to make sure we have efficiencies and money when we come to the next 3 years. So I wanted to start by defining a few terms we're throwing around and make sure that we're aligned on this. So for efficiency, this is a measure of the ability of an organization to produce the maximum amount of acceptable quality with the minimum time, effort, and other inputs. And I'm emphasizing this because it's not just a question of cutting money. It's a question of figuring out the ways to do things to achieve what we need to achieve with less resources. So don't cut money and do things halfway. We've got to find a way to find these two things to come together. then optimization is really finding the best possible solution to a problem. And this can consist of maximizing or minimizing the value of a certain function, perhaps subject to given constraints. And I think we know what those constraints are. So I've passed this message every single year. In fact, I reused some of my slides from last year. We keep doing the same things, so campaign, routine, and then CD pilots, where we have limited large-scale efforts, without really looking at either of those terms, efficiency and optimization. So we need to now review and assess what is and isn't working to achieve impact on malaria transmission. And that is everything from our channels to the strategies that we adopt for each of those channels. And the comic on the right is kind of a little bit about where I think we're probably going. So I think we need to start to review the channel selection, and we've gone through this repeatedly at this meeting. And I'm really excited to see that for tomorrow, we have a really high registration for the continuous distribution session. So that tells me that we're all thinking that we need to do things maybe a little bit differently moving forward. We need to talk about where we need to have impact on malaria transmission. And I'll come back to Christian on urban, but we've been saying that for 15 years too. Where can we have lower targets? So do we need a 95% target in a low burden area? Or can we set a 65% target and use less inputs? And then finally, we need to identify the channels that will get us to the achievement of those targets. Maybe we'll just stop on targets. Nada. Okay. A brief history of time and a reason that we don't have to be afraid. You've done it all. Every single one of these channels, almost all of you have implemented. So whether that's routine, we started in the 90s, we've been doing targeted or geographically stratified campaigns, large-scale campaigns to cover under fives, which were often integrated, community distribution, schools, continuous, large-scale campaigns, and social marketing and private sector. So put up your hand if you're a program that doesn't have experience with the channels. So it's not so hard to make a change. You know it, you've done it, and you've done it well. Okay, so with all the challenges this year, we've had to do a lot of tracking, and one of the things we've had to track as we tried to figure out what do we do with some of the gaps has been around the operational costs. And these are wild. I'm frankly just quite shocked on where we are. And so for all of us, it is in our best interest to start to understand what's driving these costs and to figure out how we can be more efficient. So we had a whole session yesterday on microstratification for urban areas. Don't do it. Just don't. We don't have money for it. Urban should be in or out, should not be in for mass campaigns. We've said this for 15 years. If somebody would give us a recommendation, we could actually get programs to adhere to it. If you need to do urban because you have a burden, figure out the right channels, because campaigns don't really work in urban areas. Okay, digital people. We've been talking lots and lots about digitalization over the last several years. I would argue that we're not fully using the potential of the digital tools and the digital data in how we're taking decisions and in the operations, and there are areas we can improve and have more efficiency. So this is everything from micro-planning, Madagascar's excellent presentation on e-training for a program that does not digitalize its campaign. Yet, there are many of you digitalizing who are doing face-to-face trainings, so I'm a little confused on how we're not using digital platforms for training more effectively. Voucher alternatives, this will be discussed during the digitalization meeting. Supply chain and tracking, which will be discussed again tomorrow. And then supervision and monitoring. You have these beautiful dashboards, and we send thousands of people from the central level, I guess, to access the dashboard at the low level where you have less internet connectivity, which again, doesn't seem to make a whole lot of sense. So figure out how we can do better with these tools, and I think Joris's presentation really showed us we can find some optimization and efficiency with those tools. Oops, sorry. Microplanning. I am a big fan of microplanning. It's probably my thing I think is most important, but I think we can optimize it. We can build on existing work with geospatial tools and talk to the vaccination program. They're doing a lot of work. We can establish georepositories for the reuse of maps and data. We can pre-populate simplified templates, use our previous data, provide some parameters for changes, and then, have a way to rationalize the population. We could update rather than develop microplans every time. And we could tie microplanning and registration together, which is an approach we will be using in Sudan, a very difficult context, to try to get to a campaign that might work in the middle of a war. So some of you will see a few points on here that might be a bit specific. For ITN allocation, we have options. We can round up. We know Mali used to round down because their routine system was functioning so well that they could give less nets in the campaign because they had enough nets in the household. So in that case, strengthening routine allows you to optimize your campaign. Find free venues for your training. Use some e-learning. Don't budget for blanket mop-up. Similar message from last year. Don't buy rain gear or other extras. We should go with nice to have versus need to have. So we want to only focus on what we need. Don't do door-to-door hangout. It went out a long time ago. I'm not actually sure why I still see it in plans. And then for payments, they're a problem. And I think we all recognize there are big challenges with this, but make a plan and let's not extend our implementation by weeks. WhatsApp groups that are going for months after the end of the distribution with people that haven't been paid. There's a knock-on effect, and there's first our own efficiency, but then there's second the knock-on for other health programs. Optimize the supply chain. So can we find areas where we can be more efficient? Can we use fewer levels in the in-country supply chain? And we should really work to ensure government support for warehousing at national and subnational levels. Nigeria has great experience doing digital warehouse assessments, so then we don't have to send everybody to the field to look at the same warehouse every 3 years to see if it's changed. And then the private sector has a role to play on our supply chains. So not just as a contractor, but they can support us in strategy development and execution, and they can provide in-kind contributions for both actual logistics, but also expertise. And the last one, my friends over here will recognize, over there, don't request additional money because we've created a bubble. So in some countries, what we see with the 3-year campaign cycle, your warehousing, your transporters, they all know it's coming. So all of a sudden, those warehouse costs jack by 50% because all of a sudden people know there's money in the system. So I think we've got to find ways to avoid creating that bubble, that economic bubble linked to campaigns. Okay, my poor SBC people, you know how it all works when we don't have enough money. Use the data to plan it to make sure that we don't get everything cut, okay? Because right now I think we recognize the risk that SBC has, at the same time as we recognize the importance as we start to change how we're targeting and distributing and delivering nets. So This is one that we're really going to have to focus on, I think, as a community. We see a lot of people recycling their SBC, not necessarily looking at what worked and what didn't. You really need to use the data to target your SBCC to where you actually need that behavior change. And then you need to figure out the activities and channels that will achieve your desired behavior change. Transfer launch costs to government. If you consider that it's a priority to launch your campaign and have a political event, then pay for it. But no survey I have ever seen in 20 years of campaigns has told me that the launch was a household's main source of information. It's not ever the main source of information. We've talked about integration, and I'm really happy with the DRC response on EPI. Again, we have lots of experience here, and this could support our quantification, get us to a reduced ITN need. We have an easily identifiable target group with kids under 5. If you can reach your ear, you're over 5. It's pretty simple to check that. So get us out of a registration and a heavy process. And then obviously when we integrate it, it allows us some efficiencies around microplanning, training, SBC, supervision, and monitoring. Okay, we also are going to need, and I think this came out yesterday, and we saw the excellent presentation from Somalia, but we need some cost-effective ways to measure the key indicators and track our progress over time so that we can take programmatic action where our data says it's needed. But linked to that, we need to prioritize the collection of data for decision-making and not for reporting. So we need to ensure that the indicators we're measuring and the methods that we're using for the data collection are going to allow us to take programmatic action, not just write a report, and to think about if we can't take an action on our data, do we need to collect it? So let's be efficient on what we do and don't need for data. Ghana, do you like this one? So if you want to talk about private sector engagement, I think Ghana is quite advanced with this. The link underneath for the YouTube is an example from Zambia of the use of Coca-Cola to move commodity down to last mile. This is probably more than a decade old. I feel old, but maybe Chris will tell me. But I think it's quite old, but it doesn't mean we can't look at it again, because I think we need to start to look at things we were looking at 10 years ago in potentially a different way. So it is going to be a difficult few years. The title of this slide last year was, "It might be a difficult few years." I changed it to say that it will be a difficult few years. So funds are going to be insufficient, okay? I mean, there's no question. We are not going to have enough money to maintain vector control. We're very good at scaling up, but I think now we need to rationally think about how we scale down. And it was really easy to go up because you just gave to more people, and taking things away is much more difficult than giving more. And some populations are not going to be targeted, and it's not because they're not at risk, but we can't stretch our resources to cover everybody, and this is why we're going to have to prioritize where we want to have an impact on malaria. And I'm reminding you that operational costs need to be addressed to improve efficiency, and I'm reminding you that the definition of efficiency is not just saving money, it's achieving a maximum output of acceptable quality with a minimum of time, effort, and other inputs. And we need to think far more seriously about channel diversification and maximizing the channels that are reaching the people that we need to reach. So what's next? I put this in, this is a storyboard around stories of innovation. Many, many, many of them are from you. They're from Africa. So for me, change and innovation is going to be led by the planners and the implementers in the malaria-affected countries. We have our own problems at the global level, but we can't take decisions for every country. So we need you to take the decisions so that we don't have to force them down your throat. So use this power that you have of innovation and thought and digitalization, and bring us the solutions that you think are going to work. So, improvise, adapt, overcome. We change our plans, but we don't change our vision. And I think that's where we want to stay focused over the next short and long period. And finally, I just wanted to say we are organizing a monthly technical session. These are different topics. It can be geospatial mapping, it can be whatever. You're welcome to join these. So we send out the topic every month in advance, and you'll know what the topic is. If it's of interest, it's of interest. There is interpretation on these calls in both French and Portuguese, so we very much have tried to open these up to all programs to make you feel welcome. And we also would be more than happy to highlight those innovations that we're hoping to see over the next short, medium, and long term as we face these new challenges together. Thank you.
Thank you so much, Marcy. You got me thinking. Okay. You want to ask all questions? Is it clear enough? Any need for clarification? Are you afraid?
Last year everybody complained there was no Q&A, so I added it this year. You see, now no one has anything to say.
Okay, so if we don't have, okay, we do have. Okay.
Short comment. So yeah, thanks so much, Marcy. It's both inspiring and terrifying. So maybe just a thought is that all of us in this room have the benefit already of starting this change management process, but those outside the room have not, many of whom we will be working closely with so we can manage that process. But one group of people, and I know that through the preparation of the information note that we are preparing some of the changes, but to the extent to which the messages in these slides are translated for particularly TRP review members may be helpful, because otherwise that change process may not be translated there. So sorry, Kate, but just thinking ahead that maybe some more direct or directive language needs to be in there as well. Over.
So I'm not speaking for Kate, but I am saying AMP is always willing to help the Global Fund to think through the new guidance on the concept notes.
I will just add something if I can. So yeah, Mary, there is work in progress to try and translate the guidance from WHO, but from AMP, and to request the guidance that we think we're going to need direct to Marcy, and make sure that the guidance that's coming is fit for the purpose that the country teams and the PRs are going to have if it comes to reprogramming, or certainly for designing the grant cycle 8 grants. So yes, but speaking to the TRP, that is true. That does need to be quite high up the list. Thanks.
Okay, if we don't have any more comment and a question, join me as we give a round of applause to Marcy. Thank you.
Good. I just wanted to give a round of applause to our last session chair, Dr. Wepo, who did a fantastic job. And before we close, I would like to invite Dr. Kibor from Ministry of Health Kenya to come up. He was going to, welcome. So obviously Dr. Kibor was with us yesterday morning, and his boss, Dr. Joseph, was trying to attend the meeting, wasn't able to attend, but just wanted to share some words with us. So Dr. Kibor, over to you.
Thank you so much. And as I welcomed you yesterday, we are still here. And if you've had any challenges, we apologize for that. And we hope that you've had a good stay. As we come to near end, there is a meeting in Mombasa where Dr. Lenai has gone to and has shared with me his speech for this meeting, which I will just read. These are remarks from Dr. Joseph Lenai, OGW, Head of Directorate of Primary Healthcare, State Department for Public Health and Professional Standards during AMP Annual Partners Meeting in Movenpick, Nairobi. A representative from IFRC, Global Fund, WHO, national malaria programs from various countries, ladies and gentlemen. It is my great pleasure and honor to address you today on a subject that remains central to our public health agenda, the fight against malaria. Kenya has long recognized malaria not just as a disease, but as a barrier to social, economic development, disproportionately affecting our most vulnerable population, children under 5 and pregnant women. As such, it has remained a top priority in our national health strategy. Over the last decade, Kenya has made remarkable progress in the fight against malaria through a combination of government leadership, strong partner collaboration, evidence-based interventions, and the tireless work of our national malaria, of our health workforce. We have successfully reduced the national malaria prevalence by more than 50%. In real terms, this means fewer children falling sick, fewer missed school days, fewer families suffering the devastating impact of losing loved ones to the preventable disease. These gains have been achieved through deliberate high-impact strategies, including the distribution of long-lasting insecticidal nets, targeted indoor spraying, scaling up of intermittent preventive treatment in pregnancy, prompt case management, and sustained investment in community health services. Behind these interventions is a well-trained and committed health workforce and an evolving surveillance and data systems that inform every decision we make. One of our proudest moments in the recent years came during our most recent insecticide-treated nets mass campaign. For the first time, we leveraged an in-house developed digital application to plan, track, and monitor distribution in real time. Through this innovation, we reached more than 28 million Kenyans and were able to verify that approximately 14.6 million ITNs reached this population. This represents more than 80% coverage in malaria endemic regions, surpassing the World Health Organization's threshold for achieving meaningful reduction in malaria transmission. This example illustrates how digital health tools can help us improve accountability, effectiveness, and ultimately health outcomes. But as we reflect on the successes of the past, we must also prepare for the challenges ahead. Kenya, like many malaria endemic countries, is experiencing shifts in global health funding landscape. The financial resources that once enabled us to scale up interventions rapidly and comprehensively are beginning to plateau, and in some instances decline. This reality requires us to do more with less, to sharpen our focus, target our efforts where the burden is highest, and build resilient systems that can sustain the gains we have made. Moving forward, data will continue to be our compass. We must deepen our use of surveillance systems to detect disease trends quickly, identify emerging hotspots, and guide localized responses. The government of Kenya has already laid the groundwork by strengthening routine health information systems and investing in malaria-specific surveillance platforms. These systems enable us to monitor disease burden, in near real time and adjust our strategies based on the expected variability in malaria trends as resource flows and intervention coverage fluctuate. We also recognize that the malaria landscape is changing. Globally, the malaria community is transitioning from a period of abundance to one of constraint. For over a decade, we benefited from unprecedented investments that helped scale up life-saving interventions. As we now enter a more resource-limited era, solidarity, innovation, and strategic focus will be more important than ever. Kenya remains committed to working with regional partners and global actors to advocate for sustained investment in malaria elimination and to share lessons that can benefit the broader community. This means that blanket approaches may no longer be sufficient. Instead, we must design intervention packages tailored to specific geographies, population groups, and levels of risk. Such a shift requires both innovation and flexibility in our policies, our operations, and our partnerships. Equally important is the role of communities. Community health promoters and civil society groups are essential in building awareness, promoting preventive practices, and ensuring early care seeking. Our fight against malaria will be won not just in hospital and clinics, but in households and villages through the power of informed and engaged citizens. Health workers remain at the center of this fight. As the disease evolves and new tools become available, our frontline staff must be equipped not only with commodities, but with knowledge and skills and adapt to the changing context. We must invest in continuous malaria services. We must invest in continuous training, supportive supervision, and integration of malaria services into the broader framework of primary health care, especially as we move towards universal health coverage. We know that the road ahead will not be easy. Setbacks may occur, and progress may be uneven. But let us not be discouraged. We have seen what is possible when we combine political will with technical expertise, innovation, and community action. The reduction in malaria cases and deaths across Kenya proves that our strategies are working. We must protect these gains and accelerate towards ultimate goal of malaria-free Kenya. I would like to extend our sincere appreciation to the Alliance for Malaria Prevention for once again choosing Kenya as the host for the annual partners meeting. We do not take this honor for granted. Kenya remains fully committed to the shared mission to leave no one behind, to make every shilling an intervention count, and to envision a future where no Kenyan and no person suffers or dies from the disease when we have tools to prevent and treat. In the face of shifting resources, we are also committed to doing more with less. By optimizing our strategies, leveraging innovation, and focusing on high-impact interventions, together we can make the future a reality. Remarks from Dr. Joseph Lenai, Director, Preventive Healthcare. Thank you so much. I know we are coming to close of the partners meeting, and there will be other meetings tomorrow to focus on specific technical areas. Thank you so much, and we appreciate your participation. We appreciate you choosing Kenya to work with us, and we will always be available when called upon to embrace these innovations we discuss about. And I like the learning curve that we've seen. We've made gains over the past, things that we thought were not workable. I remember when we started digitization of MassNet, and one of the evaluators told us that this system is only 30% ready, you cannot use it. Because, you know, those people they call ethical hackers would tell us you cannot even pay through the system, but we managed to do it fully, and there were quite a number of savings, which even helped us to reach out to other population in that could not be, could not be possible if we had not digitized the process. So innovation is the key to enhance better future, better utility, and better return on investment. So thank you so much. Over to you, Eugene.
Good. Thank you very much, Dr. Kabor. I would like to now invite Dr. Mark Grabowski to come up and provide some closing comments for the 2025 AMP Partners Meeting.
Thank you, Jason. Allow me to congratulate you. When we started this program, we took as our model the EPI program, which had an enormous amount of experience in delivery, polio campaigns, measles campaigns, routine delivery. And this was their benchmark of DPT-3 coverage that they used to measure their program performance. And the hope was that over time, this program might perform as well as the immunization programs. So this is the data over time from the beginning of the program, showing households with NETs. And what you can see in 2023 is that this program has exceeded EPI for the first time. And so that you are now the best performing program in Africa. And that deserves an applause. But coming from me is not as important as coming from your peers and your colleagues. So what I'd like you to do at this moment is turn to the person next to you who's part of the program, who's at the table sitting next to you, and just say congratulations. Say thank you. Give them a kind word for their effort. All right, save some for next year. They'll be even better. This program continues to change and evolve. And I'd like to make a few words about change and evolution in this program. If you were a gentleman scientist in 1840 in England, you thought this was the most important book ever published. It's The Principles of Geology by Lyell, and in it he describes what's happening with change in the world. And if you look at the left-hand side, he has those columns that you see in the picture, and those columns exist today in the town of Pozzuoli, which is near Naples. Let's take a closer look at those columns and why he put them in the book. In those columns, there's about 3 meters up from the bottom in the circle is a series of small holes which are put there by a marine mollusk called Lithophagia. And what this means is that these columns at one point were submerged in the ocean. And then later at some point, they rose up back again into dry land. And yet, over the 2,000 years since the Romans built these, no one ever really remarked on this process of these columns going down and going up, and the columns are still standing upright. Lyell interpreted this to mean that this had not been a violent process. There had not been earthquakes or volcanoes or tsunamis that caused this, but rather it was a very slow and gradual process. And then he looked at the top of the column, and he could measure the amount of erosion due to wind and weather on the column. And then he found the mountain from which these columns were quarried, the stone. And he could see the vast amount of erosion of those mountains. And he could measure the amount of time it took for that erosion to occur. And it was millions of years. And the reason this book was so important was because the common understanding at the time was that the Earth was formed in 7 days, through miracles, and the Earth was less than 4,000 years old. And so this was earth-shattering, and he called this theory of change uniformitarianism. That is, there were slow processes occurring over time. Now, this theory wasn't just a scientific theory, but it was also culturally useful. And that is, if you were an aristocratic young person in England at the time, you were very concerned about your social status. You were concerned about social change. You were concerned about the emerging revolutions happening. And so a theory which said that change is gradual and took millions of years was very comforting to the aristocrats at the time, and they fully embraced this theory. One of the people who embraced this theory was a young colleague of Lyell's who was about to embark on a 3-year voyage on a ship called the Beagle, and that was his friend Charles Darwin. And Darwin fully embraced this theory of uniformitarianism. Things happen slowly over time. And when he wrote his book, he incorporated that theory in his theory of evolution. And if the vertical axis on this chart of these butterflies is time, and it's millions of years. And his theory was simply that you'd started with a common ancestor, and over millions of years there'd be transitional forms, each one of which had 1 million years for it to exist. Then you'd reach the form we would see today as the final form. And this theory depended upon one thing. It depended upon finding those intermediate forms. That is, we assumed gradual change over time. And surely there would be millions of years for these intermediate forms to exist in the fossil record. His book was published in 1859, and over that intervening 100 years, we didn't find the intermediate fossils. We could not find anything that suggested that, in fact, this uniformity happened, slow change over time. In fact, what we saw was what we see on the right, is that sometimes the common ancestor stayed the same over millions of years. And when fossils occurred, new forms occurred, they suddenly appeared without any intervening forms. And then those new species that appeared stayed the same over millions of years. And so in 1972, 100 years after Darwin, a guy named Stephen Jay Gould published a book called Punctuated Equilibrium, which described a new theory of change for how the world operated. And he was a guy who looked at microscopic snail fossils in the marine beds, and he could drill down in the marine, and he could use his microscope, and by looking at the deeper ones were older and the shallower ones were newer, he could measure over time change. And this is the graph that he shows in his original paper. On the left shows the rate of change of these microfossils, and the bottom shows time, later time on the right. And what he saw was there were long periods of stability, that the fossils changed very little and certainly didn't change in a uniform way. And that there were long periods, as you see here, which there was very little change. But there were other periods in which there was rapid change. And he called this punctuated equilibrium. But he also understood something about DNA. And he understood that DNA copied itself extremely faithfully. So this is a picture of DNA with the DNA polymerases and DNA editing and checking and proofreading enzymes. So it's very hard to change DNA. So according to his theory, he understood that long periods of stasis were consistent with what he knew about biology. And so in his model, he understood why things stayed the same, but he didn't quite have a theory yet as to why things changed suddenly. And he looked back at his data, and he could correlate these sudden changes with ice ages. That is, that there were rapid changes in the world, in the environment. And so we also thought back on other catastrophes that we had, such as asteroids wiping out the dinosaurs and dramatic volcanic eruptions which changed the climate, and two active sunspots, and a whole range of things, which were then these catastrophes, which were these punctuations in the punctuated equilibrium. And here's a model of how these two things work. Gradualism, that organisms themselves are ambivalent to change. They respond to persistent external forces with gradual change. In the punctuated equilibrium, organisms are inherently stable. They respond to sudden, strong external forces with rapid change. So what does this have to say to us in our time of change now? Well, the first is that we are inherently stable beings over some period of time. But we trick ourselves, either culturally or other way, into expecting the world to also be stable. That we have an observation bias about stability. Secondly, we perceive change as abnormal and threatening, rather than what's truly happening in nature is that it happens periodically. But third, when we recognize that instability is normal, we can move from being victims of change to being active participants in change. And so this is Stephen Jay Gould's comment on the asteroid that hit the dinosaurs, that they've been around for millions of years, and then all of a sudden came crashing down in an instant when the Earth changed so quickly, and they couldn't adapt. But there were those that could adapt. And this is how to flourish in a changing world. And one of the reasons I know that you can flourish make it louder. One of the reasons I know that you can flourish is because your relatives have. And this is one of your relatives. His name is Purgatorius. He was a mammal that survived the asteroid impact 65 million years ago. And he may be the ancestor of us all. But he flourished in an extraordinary way. And here's the reasons that he flourished. And you can look at these factors and apply them to yourselves. Many of you are already applying these factors. Be nimble. He was certainly more nimble than the dinosaurs. He was efficient. He was warm-blooded. He was the first warm-blooded creature. And he could use energy more efficiently. He diversified his resources. Instead of being a meat eater or a plant eater, he ate nuts and insects and worms and everything that he could find. He was an omnivore, and so he expanded the use of his resources. He also found new niches. He lived in the tops of trees. He lived underground. And he was able to exploit areas that others had not exploited. And finally, he wasn't very smart. He had a very small brain cavity. But what he was interested in was performance over analysis. And he was able to use these tools that he had to achieve an end. So the second reason that I believe that you're going to succeed in the face of change is because you've already done it and demonstrated that you can. So this is the blue line of our success over time. And a lot of things have happened over those 20 or so years. There was 9/11, the Iraq War, SARS-1, the Indian Ocean tsunami, Japan earthquake, the US financial crisis and the global recession, the EU debt crisis, the Chinese stock crisis, COVID-19, and many others have occurred. All of these were challenges, maybe more so to some partners than others, but throughout, you had a continuous record of success. So I have great confidence that this is going to be difficult, but that you've demonstrated that you can handle, maybe not of this magnitude, but certainly of kind, challenges. So I'd like to close with this thought. There's a story from Persia that a monarch once charged his wise men with inventing a sentence that despite a changing world would be true and appropriate in all times and all situations. And that's a sentence written in Persian. And in English, this too shall pass. So thank you all, and congratulations. See you next year.
So I wanted to thank Mark Grabowski for those inspiring closing words. And Mark's available for kids' birthdays, weddings, anything. I think he pulled that together from yesterday morning to today. So he's, anyways, just I'm plugging for him. You can come see me. Don't talk to him directly. Talk to me first. I charge a small fee. Look, I wanted to invite the core group to come up. And when you come up, could you bring up a remote microphone so we can do the awards for this year? We just need a remote microphone for that. Good, and what I'll do is as the core group comes up, obviously, just like what we see in the room here, normally we would have more core group members with us this year. There's a number of, all the rest of the core group is online. So if we could just quickly, if we could pass the mic, Marcy, and just have each person introduce themselves and the organization they work with, just so you get a sense. There's 16 of us in total, and there are 6 of us here. But if we could just quickly pass the mic and just each of you introduce yourselves.
Hi, I'm Jessica Rockwood, International Public Health Advisors.
Bonjour à tout le monde, moi je suis Dominique Guinaud de Catholic Relief Services.
Hi everybody, I'm Cedric Mingat from Walton Health.
Kate Kolozinski from the Global Fund.
Marcy, IFRC AMP.
Good, and just as a number of you would know that join our weekly calls, we have actually a consultancy group working with us to say how can we improve this core group. They're going to finish their work next week. We'll put that report out, they'll present to us. What we're hoping to do is open up the core group for additional participation. And our focus is really to get countries with a malaria burden onto the core group, so watch this space. So now we're going to start with the AMP Awards this year, and I'm going to hand over to Jessica, who's got the first award.
Hi, I'd like to ask Dr. Kibor, is he still here?
Okay, I'll do that with Rainer. Do you have anything
there he
else
is.
to say about that?
I'd like you to come up, please.
And because you are now getting back to questionnaires and then look for appropriate candidates with all careful thoughts, which we shared already.
So, Dr. Kibor, we'd like to thank you and the government of Kenya, and the Ministry of Health,
on April 15th
for
in
hosting
1
us
week.
yet again this year. We'd like to congratulate you on your completion of your
we could set up a meeting
campaign
about
and for
3 or 4
the
days
development
after
of
that.
Digimall. Thank
Maybe
you so
before
much.
Catherine travels. Possibly. Would that work for you, Catherine? And Rainer and Larry?
18th is fine. For me too.
Should be fine. I just other meetings on Friday, so this will be no time.
Okay, the next award is the award for using data for decision making, and it honors the memory of Dr. Jorge Alexandre Harrison Arroche, who's the former technical malaria manager at World Vision Mozambique, whose passion was to utilize quality data to ensure continuous improvements in program planning and implementation. So as presented during day 1, yesterday, this country launched an ambitious review project to learn how people in 26 districts own and use mosquito nets following their 2022 mass campaigns. They looked at coverage, ownership, usage with qualitative and quantitative methods to inform, target, and prioritize future campaign planning in what is often a very complex operating environment. So the MP Core Group proudly presents this award for utilizing data for decision making to the Somalia NMCP and all of its partners. Congratulations, Somalia.
I have kind of a weird one this year. So I'm providing the award in honor of Dr. Samuel Smith for leadership. And I've been very fortunate over the last little bit to be participating in a lot of calls with the team from the country of Dr. Smith. So just to say we're really happy with the work you're doing around, the scenarios for looking at, what you're going to do for schools, what you're going to do for IRS, really showing the leadership of the national program to make the most of what you can with what you have. So I want to award Team Sierra Leone, Team Salone, can you come up, for leadership this year.
Good, and I have the final award for AMP in 2025. And this is a difficult award to award because the group that will receive this is not in the room. And I just wanted to acknowledge David Gittleman wrote these words for us, because when we met over the weekend, it was quite difficult as a core group to put this together. So AMP celebrates with enormous gratitude the over 20 years of contributions to global malaria prevention achievements by the United States government through its President's Malaria Initiative. PMI and its implementing partners established an extraordinary collaboration with national malaria programs and their partners to champion innovation, technical training, strong logistic systems, and visionary country leadership of ITN programs. Name most any aspect of ITN programming, and PMI stood ready to help. Best practices for campaign and continuous distribution, ITN quality and durability, development, procurement and supply logistics, quality monitoring and impact evaluation, just to name a few. Also, when you look at us now, we're huge, but PMI gave strong technical and financial support to AMP in our early years when we were threadbare with staff. And they funded AMP's technical leadership, our program leads, and they were very, very active members of our core group. The US government should be extremely proud of its investment and the millions and millions of lives saved over 2 decades. And as the US government considers how it may support malaria programs going forward, AMP stands ready to explore new ways to collaborate. Partnership for preventing malaria transmission benefits all countries. Thank you, PMI. And I would just ask if we could all stand and give a round of applause to the PMI team and to PMI in general. So that's their award. Now we're going to transition to really the best part of the meeting, and this is when we award the capes. And just to be clear, this was a tradition that was started by Drake Zimmerman, who's a member of the core group, by the Rotarians. And for us as a core group, we felt these technical awards were important. Very, very quickly, it was clear the super person capes were much more important than any dodgy award AMP could give you. So we're going to start, and then the first country, how are we going to run this? So we're going to go. Actually, you'll do car. So the first country we're going to award, I will hand over to Jessica, maybe. And you're going to cover, you got the first one?
Yeah. Yep. So the first cape, will go to Guinea-Bissau. If I can ask Guinea-Bissau to come up, please. Obrigada.
bonjour à tous. Donc moi j'ai le grand plaisir d'offrir la deuxième cape qui va être pour la République de Centrafrique. Donc avec nos félicitations au ministère de la Santé, la Croix-Rouge française et World Vision. Donc c'est Monsieur Lama. Alors qui va prendre la cape? C'est lui, hein? Oui, c'est lui.
All right, the next country who is deserving of a cape, we're very proud to award this Superman, Superwoman cape to Zimbabwe. Okay, we'll keep it.
For me, Mr. Gitania. Thank you to Peter, both for all of his contributions to the Continuous Distribution Working Group this year, the work that Tanzania is doing. This one's for you guys. Bring it Zanzibar? Yes. Good. It's good. It's good to share.
Oh, that's nice.
All right, next on the list is Mozambique. Mozambique!
Et alors je vais offrir la dernière cape à l'équipe du Bénin. Est-ce qu'on a quelqu'un? Bon. Personne du Bénin? Ok. Bon, je vais la garder. Ok. I'll keep it for them.
So just a few more administrative issues as we close. This afternoon you will receive a message from Oriane Barrault that will just say, thank you for participating. In that message there's going to be a link to a survey for this meeting. It's really important you fill in that survey so it helps us improve this meeting going forward. All the PowerPoints from yesterday and today will be on the website this evening, and then a recording of the meeting would be online probably by the end of this week, early next week. And then for tomorrow, when we're doing the technical working sessions, it's 3 meeting rooms on the 4th floor. So breakfast in the same spot, and we go to the 4th floor. There's one Anglophone meeting on the geospatial tools, one Francophone meeting on the geospatial tools, and then meeting with translation for IT and waste care and repair. And if you're attending the geospatial tools meeting, you need to download an app in advance of tomorrow's meeting. So that will be in the message that Oriane sends out. So if you can just check the message, and if you're attending that one, ensure that you've downloaded the app. You'll need your badge, of course, tomorrow to attend those meetings, so just please make sure you remember your badge. And then as we wrap up, I wanted to start by thanking Oriane. If you can please stand, Oriane. Oriane has done enormous work on this meeting. We had looked at moving this to other parts of Africa. She's done massive amounts of work over the last year. So thank you very much, Oriane. And then to the full AMP staff team that supported. I wanted to thank you. I wanted to thank our translators and the hotel staff who are here with us today. Thank you very much. And then most importantly, I wanted to thank us, the people in this room and the people who are online, the partnership. We are the core of this larger movement. We're that tiny animal that Mark showed us that's nimble, probably not very smart, but is nimble and is constantly adapting. So thank you once again for joining. We look forward to working together again tomorrow, and we'll see everyone next year. So thanks once again.